Okay, so once again, welcome everyone. I hope now the issue is sorted.
बेस्ट में अपने वो बनाए इंश्योरेंस गाड़ी का मेरे पापा बना जा रहे हैं मुझे बार बार फोन आ रहे हैं मारुति के इंश्योरेंस गाड़ी का
US Tata. Okay, let's
30 अगस्त को
Hello.
Once again, welcome everyone. I hope now the issue is sorted.
बेस्ट में अपने वो बनाए इंश्योरेंस गाड़ी का बना जा रहे हैं मुझे बार बार फोन आ रहे हैं इंश्योरेंस गाड़ी का
US Tata. Okay, let's
30 अगस्त
Hello. So everyone has joined, I think, now.
Oh, hi, Anu. Anu,
Start.
hi.
Hi.
Can you hear me, Anu?
Yes,
Hi.
yes, I
Can you
can
hear
hear.
me?
Yes, yes.
I am in very unstable network as of now. So you go ahead and start it. Don't invite me to talk because I won't be able to. अभी मैं गाड़ी में बैठ के बेटर नेटवर्क में जाऊंगी तब मैं बात करूंगी ठीक है तब तक you start and good evening to everyone Sachin sir good
Good evening. Good evening.
Good evening, everyone.
Oh, hi, Anu. Anu,
Start.
hi, you, Shreya, Vandana, everyone, hi.
Yes, yes, I
Can you
can hear.
hear me?
Yes, yes.
Hi to all of you. Hi,
I'm
Anu.
in
Hi,
very
Seema.
unstable
Hi,
network as
everyone.
of now. So
Welcome.
you go ahead and start it. Don't invite me to talk because I won't be able to. अभी मैं गाड़ी में बैठ के बेटर नेटवर्क में जाऊंगी तब मैं बात करूंगी ठीक है तब तक you start and good evening to everyone Sachin sir good
Namaste.
evening.
Good evening.
Good evening, everyone.
Oh, hi, Anu. Anu,
Start.
hi, you,
So should we
Shreya,
start?
Vandana, everyone, hi.
Yes, yes, I
Can you
can hear.
hear me?
Yes, yes.
Hi to all of you. Hi,
I'm
Anu.
in
Hi,
very
Seema.
unstable
Hi,
network as
everyone.
of now. So
Welcome.
you go ahead and start it. Don't invite me to talk because I won't be able to. अभी मैं गाड़ी में बैठ के बेटर नेटवर्क में जाऊंगी तब मैं बात करूंगी ठीक है तब तक you start and good evening to everyone Sachin sir good
Namaste.
evening.
Good evening.
Good evening, everyone.
Hi, Anu. Anu,
Start.
hi, you,
So should we
Shreya,
start?
Vandana, everyone, hi.
Yes, yes, I
Can you
can
hear
hear.
me?
Yes, yes.
Hi to all of you. Hi,
I'm
Anu.
in
Hi,
very
Seema.
unstable network
Hi,
as of
everyone.
now. So
Welcome.
you go ahead and start it. Don't invite me to talk because I won't be able to. अभी मैं गाड़ी में बैठ के बेटर नेटवर्क में जाऊंगी तब मैं बात तब तक you start. अभी मैंने उतना किया ना अभी देख and good evening to everyone sir good
Namaste.
evening.
Good evening.
Good evening, everybody.
देख रहे थे अनु वहाँ पे
Start.
हाय
So should we start?
नहीं तुम्हारे सामने करती हूँ वहाँ जाती हूँ कागज
Yes,
पे भूल
yes, I
जाता है
can
फिर
hear.
मारती हूँ
Yes, yes.
Hi to all of you. Hi, Anu. Hi, Seema.
I think there is some technical problem here because whatever we are saying, it's getting repeated.
मैं गाड़ी में बैठ के बेटर नेटवर्क में जाऊंगी तब मैं बात तब तक अभी मैंने उतना किया ना अभी देख and good evening to everyone sir good
Namaste.
evening.
Good evening.
Good evening, everybody.
वहाँ पे
Start. So should we start?
तुम्हारे सामने करती हूँ वहाँ जाती हूँ कागज पे भूल
Yes, I
जाता है
can
फिर
hear.
मारती हूँ
Yes, yes.
Hi to all of you. Hi, Anu. Hi, Seema.
Hi, everyone. I think there is some technical problem here because whatever we are saying, it's getting repeated.
Namaste. Good evening.
Good evening, everybody.
Start. So should we start?
तुम्हारे सामने करती हूँ वहाँ जाती हूँ कागज पे भूल
Yes, I
जाता है
can
फिर
hear.
मारती हूँ
Yes, yes.
Hi to all of you. Hi, Anu. Hi, Seema.
Hi, everyone. I think there is some technical problem here because whatever we are saying, it's getting repeated.
Hello, everyone. Ask Seema to mute herself.
Okay, so
Hello.
then now the issue is sorted. It was because of the
Okay,
YouTube live.
we'll start.
Yes, ma'am. Yes, you can start, Anuradha, ma'am.
Okay, let's go live then. Mr. Darshan, you are starting?
Yes, ma'am. Yes.
Ah,
So,
you have to invite
on
me,
behalf
then
on
we'll.
behalf of Corona Remedies, I would like to welcome each one of you, all the respected doctors, for this Cor-Connect CME Insight Series, an evening with ESARIAN, Isarians. So this is for 24 July. The timing is from 7 to 9. We have our conveners, Dr. Seema Pandeji and Dr. Anuradha Kharji. So before starting the session, I would like to hand over to Dr. Anuradha ma'am. So madam, over to you.
Yeah. Thank you so much. Uh, Good evening, everyone. Good evening, Isarians, and all the people who have logged in. It's going to be a wonderful session today because we have two stalwarts IVF specialists, Dr. Sachin Kulkarni and Dr. Anil Gudi, who are very good orators and very good teachers. So, the topic we have chosen today is about poor ovarian reserve and their response. So, we are going to discuss and dissect each and every point, and it's going to be evidence based. So, I would like to welcome for the first scientific session today. The topic is understanding poor ovarian reserve and response. Dr. Sachin Kulkarni. The experts are Dr. Rohit Gutkatia, Dr. Chaitanya Ganpule, Dr. Seema Pandey. Now, before we hand over the session to Dr. Sachin, can we do a small prayer? Can we start with a small prayer? Darshan?
Yes, yes, ma'am. Yes, we can start.
Yeah, please play that.
Just a minute. Just
Like
a
lamp
minute.
lighting, yeah.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः।
Can I have the CV of Dr. Sachin Kulkarni, please? Yeah. So Dr. Sachin Kulkarni is a consultant at Sunanda IVF Kolhapur, head of Department of Fertility and Reproductive Medicine at Jahangir Hospital, Pune. He's teacher at Reproductive Medicine courses at Dubai, consultant New Leaf Fertility Center, Addis Ababa, and he regularly conducts fellowship programs in IVF and reproductive medicine. So it's an honor to have you here, sir. Welcome. I would like to invite Dr. Rohit Gatgatia. Can you display the CV, please? Dr. Rohit. Yeah. So he's medical director, Nova IVF Fertility India. He's graduated from Medical College, Kolkata. And his areas of interest are andrology, quality assurance, and COS. He has experience of more than 18 years and he has done full-time practice in reproductive medicine. So welcome, Dr. Rohit. Our next expert is Dr. Chaitanya Ganpule. Dr. Chaitanya's CV. So he is diploma in gynec endoscopy from France and Germany and is a certified laparoscopic surgeon, IVF specialist from London. He's director Neo Women Clinic and Hospitals and director Yash IVF and director Satara Yash. He has a lot of awards and accolades, recipient of Times Health Icon 2020, invited faculty and publication in national and international journals. And he has written chapters in Jeff Coates' textbook of gynecology, Foxy Focus. And welcome, Dr. Chaitanya. I would like to introduce my dear friend, Dr. Seema Pandey. She doesn't need much introduction. She's the Dr. Seema. She is president of Azamgarh OBG Society, librarian ISAR 2426, National Committee member, executive member of ICOG, SPAT, Commonwealth Association of Health and Disability. She has written a lot of books. Her very famous book is A to Z in PCOS. And she's co-editor of ARG and Fertility Enhancing Surgeries, Ovulation Induction, Foxy Handbook of Drug and
Bas, bas.
Infertility. So over to you, Dr. Sachin.
Well, thank you so much and good evening. Good evening, everybody. It's really a pleasure to participate in this CME as a speaker. And it has been conducted by Anuradha Madam and Dr. Seema Madam, very highly respectable people. And I've been other faculty being Dr. Goody and Dr. Lavanya Madam. And I think it's a very close group. We know everybody so well. And thank you so much, Rohit Gudkutia sir, being an expert, and Chaitanya for being an expert there. And I think everybody has a privilege and a right on interrupting me anytime in between and discussing it further, because even if few slides remain back, I'm absolutely okay with that. It's more important is a lively interaction, and even that discussion would definitely be more useful to all of us.
Yes, sir, that's
So
the
I
main.
myself stand here to present this a list of a few slides, but I stand here basically to learn from all of you and progress further. So allow me to share my screen. Just one moment, I'll take. Is everybody able to see my screen?
Yes, sir.
Yeah, thank you so much. Somehow today it's not getting presented as a keynote, it's coming as a PDF there, but that's okay. I can always move the slide up. So thank you again, and we're going to discuss diminished ovarian reserve and poor ovarian response. I specifically did not use the word diminished ovarian reserve, but we can't have POR and POR as the short forms of poor ovarian reserve and poor ovarian response. As we understand that poor ovarian reserve is something which we are testing before we start our stimulations, and poor ovarian response is something which is an experience which comes after the ovarian response. And the definition of poor ovarian response, though it is well known that such an entity exists for the last 4 decades, has always been into tips and toil for a long time. And there was a very interesting paper presented in between, which really narrated all about 40 different definitions, or 42 different definitions of poor ovarian response. So till Bologna criteria were introduced, I think there were many more definitions which were followed, and the papers could not be compared from one paper to the other. And the thought process of Bologna criteria, though we borrowed it from the Rotterdam, which is the elder brother of 2003, and this came in 2011. And there were 3 criteria of age beyond 40, previous poor response, and both of them were very robust criteria. And I feel both of them definitely across ethnicities and across nations would have a repeat poor response. But abnormal ovarian reserve tests or low AMH and AFC, so they thought any 2 of these 3 could make a difference. But age was a very heterogeneous factor there. The moment you have age associated, high age associated with abnormal AMH and AFC and previous poor response, the previous poor response at a younger age could be improved, while the low ovarian reserve test with a high age, probably because of aneuploidy problem, it could not be improved much. And it rather than solving our issues, it created a lot of heterogeneity in our reporting criteria. And even the Optimist trial and all, which were conducted on these particular scenarios, suffered a lot of statistical backlash. But I think all of us follow a certain evidence-based cutoffs in the clinic. I'm not covering the Posidone because Posidone is well known to us. We all know low prognosis patient. We classify into 1, 2, 3, 4 groups. I'm not saying that at all because all of you are expert IVF specialists, and that's day in and day out for all of you. The evidence-based cutoffs we follow in the clinic is AMH less than 1.1. That's by Bologna as well as by Posidone. When your antral follicle count is less than 5 follicles, FSH starts going beyond 10 and 12, though we need an age-based FSH levels as cutoff of poor prediction of poor ovarian responder, because an FSH of 8 at the age of 25 and FSH of 8 at the age of 31 could have a different implications. Estradiol, a high estradiol level also tell that you are probably the ovarian reserve has come down and estradiol is going up in the very day 2 or day 3 of the cycle itself. poor ovarian response, obviously there would be reduced oocyte quantity and quality, and we will use all those. We use all these parameters of age, AMH, and AFC. Age is again, we try a lot or trust a lot on the age because it is directly related to the aneuploidy. And with every year increase from 35 year onwards, there is an increased chance of aneuploidy, and our practice really changes therein. So these are the different terminologies we need to define here. We need to define diminished ovarian reserve, and I think by Simon Bro's paper in 2013 on human reproduction update really said that it's the AMH and AFC. So when you have an AMH less or FSH going high beyond 10, that would be diminished ovarian reserve. Poor ovarian responder, again, your Posidon is describing that poor ovarian responder to you. What is primary ovarian insufficiency? There will be intermittent failure, and there will be younger women less than 40 years, and AMH will be low, pretty low in these group, and FSH will be beyond 25, and premature ovarian failure when the FSH goes beyond 40. So these could be gross definitions or different terminologies we use when it comes to a story of low ovarian responder patients. Obviously, diminished ovarian reserve is very high in Indian women. What could be the reasons of that? Probably genetic, because shorter telomere lengths of genes and low mitochondrial function is very commonly seen in different genetic assessments of Indian women. And FMR1 intermediate alleles, not a classical mutation, but intermediate alleles are very commonly seen in Indian women. And that could be one genetic association why diminished ovarian reserve is seen. Intrauterine deprivation. If the female baby is born as small for gestational age with placental insufficiency or intrauterine growth retardation, probably she's born with a low follicular pool, and she starts off a career with a low AMH herself, and obviously the depletion takes place. And again, poor ovarian reserve at an earlier age is pretty common. This could be one reason. A huge amount of Indians are strictly vegetarian, so there is a possibility of high vitamin D, vitamin B12 deficiency, and trace element deficiency for a pretty long time, right from childhood to the adulthood. And probably that could be one of the hypotheses that we are could be suffering from diminished ovarian reserve. High exposure to pesticides, but well, that's world over, and chronic inflammation and metabolic syndrome. And this is, I think, pretty important. Whether it is North India or whether it is South India, the type of carbohydrate differs, but the frequency of consuming carbohydrate and the richness of carbohydrate continues. It is just parathas in the north and idli and dosas in the south, but the induction of severe long-time metabolic syndrome is pretty common. And obviously, a long-standing metabolic syndrome will have its endocrinological effects, and that could be one of the reasons, like a low-grade chronic inflammatory states these women will have for a pretty long time, and that would again deplete your follicular pool faster, and low ovarian reserve would be there. Obviously, we do see quite a high frequency of endometriosis and genital TB in some select part of India. Like I think endometriosis is all over, probably more in the south, like Kerala, Goa, etc. Genital TB, again, there are pockets of high genital TB incidence, or high infection, genital infection incidence spread all over India. Again, most of the families have become career oriented, so there is a delay in seeking pregnancy and fertility evaluation. This is typically we have seen over the last 2 or 3 decades. So the average age of treatment in all our clinics has gone to 32 and above, and it is no more 25, 26, and 27. So we are seeing, at least in the urban India, all the women beyond 32 years of age, and wherein the chances that they would be more having low ovarian reserve. If you go to the AMH decline pattern, generally the AMH levels decline 5 to 6 years before menopause across all ethnicities world over. But the starting level and the rate of decline can vary. And probably the Indian women, the starting level of the AMH decline could be different, and they may the decline trajectory could be maybe faster. And body composition and ovarian reserve also matters there. That typically Indian women with lower BMI can still have high metabolic risk. So we had published a small study on diet in polycystic ovarian, the phenotypic, and therein we had an opportunity to screen the low BMI girls who were having a body mass index between 16 to 19, and they were having single carbohydrate diet. Trust me, in spite of having a lower BMI, we did notice a low HDL level and a high LDL level. So if you go by the strict criteria of American Diabetic Association of knowing the metabolic syndrome, in India, even the girls with a lower BMI can have a high metabolic syndrome. And then this makes their state a chronic inflammatory state. And obviously, they would go and present to us as low ovarian reserve as the age advances. And this is a very interesting study. I think this was done by Manish Bankar et al. It's a SWAN study. And this was a study of women across nations. And this is a USA multicentric study was done. And I think we were compared, the Indian women were compared to the Spanish women. And what we realized is the age of menopause in Indian women is 47.2 years. And while that in the Caucasian land is about 52 years. Even in Thailand, it's about 49 years. Then there's a gradual decline of 6 years. But the similar pattern is seen in India. But higher prevalence of low ovarian reserve below 35 years is pretty common in India. And they say that the Indian women ovary or the Indian ovaries are about 6 to 7 year age faster than the Spanish ovaries. And that could be one of the reasons why we see such a large amount of low ovarian reserve patients in our population. I'm not going to go into details of this. This is, you're all very, very well aware about what is follicle output rate, what is follicle oocyte index, and ovarian sensitivity index, such as maturity index, etc. Just for the memory's sake, I'm just putting it here. So let's spend some time on this particular slide. All of us take a decision of ovarian stimulation depending on the parameters which are listed on the left side: the AMH, AFC, the FSH level, age, what is the indication, body mass index, HMG, and then you take a dose decision. You will give an FSH to them, HMG to them, or a combo to them, or a parvovirus to them, etc., etc. So the FSH dose and the duration of that is going to tell you what fort you're going to achieve. The fort is rather governed by the FSH dose or the stimulation dose. Let me be very generalistic. Stimulation dose and the duration. Then you add a trigger and the process of ovum pickup, and that again are two different confounders which are added to know what is the follicle oocyte index. So if your OPU technique is bad, your FOI could suffer. Then that FOI, the suffering of the FOI, is not related to the FSH dose and duration. So every parameter assesses a mixture of your clinical practices. So once you get a follicle oocyte index, the number of metaphase 2 oocytes you get, what is the mature oocyte rate, and that will determine how many embryos you will get ultimately, because you're going to inject only metaphase 2. That will be decided by how your trigger has acted. Have you given a trigger which is reliable enough? Have you measured a trigger? Is it a low BMI, high age client? Or there could be some various other factors. But the trigger goes is a defective trigger, and in spite of having everything normal, your mature metaphase 2 oocyte number could suffer. And then is introduced the sperm. The sperm could be an ejaculated sperm, or sperm separation methods which are used could be density gradient or macrofluidic. That would add, or it is a TISA aspirated sample or a TC sample or a frozen sperm, frozen TC sperm. What is this origin of sperm? And that will introduce another confounder, which will ultimately go ahead and decide what kind of blastocyst you get. Now it's a random chance that the kind of blastocyst you get after all the teamwork done by all these factors which we discussed, whether that blastocyst is going to be euploid or aneuploid. So if we do a study of logistic regression of putting AMH to the euploid blast, AFC to the euploid, FSH, every parameter, only it's the age which corresponds linearly with the euploidy status. The rest all may not be predictors, or the AUCs may not be fantastic compared to the age of this. So every parameter we say as the monitoring of a cycle of a fort or a FOI or a maturity index, everything is dependent on certain factors, and this slide just summarizes those factors to you. So if you use fort to determine ovarian responsive to exogenous FSH, it has some limitations. Before that, let's go to the definition of fort. The definition of fort says the number of follicles obtained between 16 millimeter and above compared to the AFC you started off. Now, not all antral follicle count is going to be converted here. Like, let's say there is something like 2 millimeter follicle or 2 to 3 millimeter follicle. Even if you give a high dose, even if you give a prolonged dose, it may not be adequate for that 2 to 3 millimeter follicle to go all the way to 16. It may go just to 14 and 15. So if you rechange the definition of fort of measuring the AFC beyond 6 millimeters, so that's probably a more sensitive herd there, and look at the follicles beyond 16 millimeter. But most of the studies are done in long agonist protocol, where you achieve a synchronization and you go ahead. Now, we use antagonist protocol. So, and again, in antagonist protocol, you can get follicles out of a 14 and 15 millimeter as well. So if you calculate fort only taking consideration 16 millimeter and above, it becomes a faulty parameter. So to use FORT as an indicator of ovarian response to exogenous FSH, you will have to shut off the endogenous FSH. So if you're using a protocol like short protocol or ultra-short protocol or microdose flare protocols, where you're triggering the endogenous FSH and you're giving exogenous FSH, the FORT is not the measure of the kind of exogenous FSH you're given because you already triggered the endogenous, and that would vary from client to client. So if you go to the SAR data, it says that 62% of IVF cycles in USA are about, are low ovarian reserve and 52% in Europe. Indian scenario, low oocyte is pretty common. Now, Indian ovaries, as I said earlier, they age 7 years faster than the Spanish women. Now, AMH here is a very complex relationship. High AMH, a good AMH, means more antral follicles are available for stimulation. But at the same time, AMH resists FSH action by aromatase inhibition, and that will reduce FORT. So it's a very dualistic thing. One side AMH makes you happy, on the other side, it is going to be a resistive force as well. So your dose may have to be adjusted accordingly. And again, if you do a study giving predominance to AMH in evaluation of your stimulations, and if you put AMH in the denominator, well, the results go completely haywire and nothing is interpretable. Like you get 2 metaphase 2 sites and the AMH of this lady is 0.2, your index will come, well, 10. And if you have 10 metaphase 2 sites, AMH is 1, it is still 10. So it is completely not interpretable. So you cannot use AMH in the denominator in assessing the response parameters. So outcomes will be different. So let's look at the predictive ability or area under curve for AFC and AMH. And this is a beautiful study by Simon Broad, long time back, 2013 publication, Human Reproduction Update. And she said, well, AMH, AFC are the most relevant ones. The precision of determination of ovarian response is very, very high, especially for determining the low as well as the high response. And that's exactly the thing what we follow. Age is a very more predictor of aneuploidy, but does not predict the ovarian response as such. It is the reserve parameters. Ovarian reserve parameters are more sensitive to that. FSH, again, is not one of those great precision predictor. But all these are papers based on long and ANTA protocols, long protocol or antagonist protocol. And nowadays, I assume a lot of you are doing PPOS. So does this replicate in the PPOS protocol? So this is a study in 2019 by Frontiers of Endocrinology by Huang et al., where they looked at the AMH in prediction of ovarian response to the PPOS protocol, and the story repeats, whether it is a prediction for low ovarian reserve, low ovarian, or low oocyte obtained or a high oocyte obtained, is the AMH, which is a very, very robust parameter to look into. But we are predicting a very dynamic nature of follicular growth. It depends on many factors, depends on AMH, FSH, BMI, age, but then we really don't know how much amount of gonadotrophin you're giving is actually going to the granulosa cells. Are there any immune antibodies not allowing a gonadotrophin action? And what is the receptor status? What is the receptor polymorphism, which you're going to experience? That would also determine the response. And unfortunately, this has not been a part of our counseling session. I feel this has to be part and parcel of counseling, that these are certain things which are not, which the science is not aware about. And the client should know it very well so that they can adjust to the fact that they got less oocytes at the end of stimulation. What about receptor polymorphism? So I just put it to ChatGPT about what is the receptor polymorphism status in Indian women, and they say that, well, it is pretty common. Your aspargine to serine 680 is pretty common, and if you have a GG homozygous, there is a lower sensitivity to FSH and poor response could be there. So if you get a poor response, well, the many times we retrospectively look into it. We are not doing any prospective studies. I'll come to one of them. And what happens with the FSH receptor polymorphism? When you have a high GG kind of serine genotype, there is a poor response, and approximate frequency is about 30 to 45%, pretty high, isn't it? So all of them will require higher doses. Fewer oocytes will be retrieved in spite of giving higher doses, and a lot of them will have a normal AMH and AFC and age as well. So phenotypically, when you look at the age, AMH, AFC, they would be normal, but the genotype is abnormal, and that's why your response suffers. So obviously, all of us are using, I think, 300 and above. All of us are making a combination of an RFSH and LH in our stimulation protocols, and we are trying to avoid this kind of problem in our population. Rather than investigating, we're just stepping up the dose and going ahead with the stimulation, which is the right decision to take, no doubt about it. So we've been doing it's an ongoing study we're doing. It's a non-selection trial in IVF stimulation, wherein we're drawing blood on the day of OPU and submitting it for receptor polymorphism studies of FSH and LH. So our stimulation decisions are not based on the receptor polymorphism. Neither is our embryo transfer detail. And what we found with the interim analysis of about 111 cases or so, there is 60% incidence of RS229C275 LHSGR gene receptor polymorphism. So LH receptor polymorphism is 2/3 of our women suffer from that. So no questions asked about adding LH to every stimulation, going a little higher on the stimulation in all your protocols. Now, the next question in the Indian scenario, what can a long-term cardiometabolic irregularity and will it affect the ovarian response? So yes, there will be a general systemic inflammation. So the trajectory of AMH fall will be faster. Sadly, in spite of our practices for such a long years and exposure to metabolic syndrome, we hardly advise an obese girl to save her eggs. We're not telling her egg freezing just because you're obese. Because she has a systemic inflammation, her trajectory of AMH decline is going to be much, much faster. So they would also have poor granulosa cell function, poor FSH signaling, poor vascularization of the follicle, and mitochondrial health of the oocyte because of the high leptin level. That would also suffer. And all that will be replicated or will result into a low ovarian response in spite of the age and everything. So these are two papers by Lee et al. In 2021 and Cannon in 2016. They talked about if you have a non-PCOS women with normal reserve, metabolic derangements will impair folliculogenesis. And they did say the IVF outcomes are negatively influenced by high waist circumference, low HDL, and hyperinsulinemia. So I think a pharmacotherapy and cognitive behavioral therapy, an integration of that for our obese women, and a timely egg freezing. It's something that should be a big drive taken by ISAR. I feel I'm particularly saying ISAR, IFS, and FOXY. They should take this drive of egg freezing for obese women, and that would be one good social activity to do. Controlled ovarian stimulation means there's a recruitment, growth, and maturation. And if you just look at the number of metaphase 2 oocytes and antral follicle count, I think a ratio of that, I think we are really oversimplifying our judgment. We still do not analyze. If you do all these FORT and FOI and maturation index, we still are not analyzing insufficient response to the first 5 days. We are not analyzing the lack of FSH dose adjustment. Hardly anybody is reporting the FSH dose adjustment done in the cycle in their studies. Insufficient response. If you do a dose adjustment, did the insufficient response continue? Insufficient response to trigger, errors in trigger administration. How many of us are publishing studies or not publishing, how much of discussing that, we did about 100 cases and about 20 of them just got 2 sites in spite of being normal AMH, and that is pretty common, as common as about 5 to 6% of the population could have it, and center to center there will be variation. So we need to have more parameters than oversimplification of our FORT, FO, and metaphase 2. And this underperformance could be biological characteristics, which is low, but there could be some other characteristics which are responsible. It could be operator related. Your skill of doing OPU is not great. Your USG machine is poor, not showing some follicles there. Your OPU pump is not functioning well. And also the technique and ability of an embryologist. You're given a lot of clotted material to that fellow, and he's taking the clot, dissecting the clot and taking the oocytes out, and their ability to identify oocytes. All that is going to play a role when it comes to an FOI and metaphase 2 maturation index. So these are not reported when we talk about KPIs. So is there a need to increase FORT? I think it's very much we need to, because IVF is a number game and oocyte quality cannot be improved. So we can only improve the quantity. So how do we increase FORT? And these are the measures. You would RFSH, RFSH plus LH, RFSH, HP, HMG, whatever, but you need to increase FORT. You need to give, I'm not using the word low or high. We need to give an appropriate dose and an appropriate trigger, an appropriate duration of stimulation as well. So most publications which are done on FORT are after most of that data comes from long agonist protocols of yesteryears. So most of it is after synchronizing of antral follicle count at the start of stimulation. So suppose you have follicles which are 10 millimeter that is not your AFC. Now, they could be giving you an egg later. So your FORT calculations could go beyond 100% also. So in an antagonist cycle, there is always an innate asynchrony. And that is a norm of practice today. We are no more using long protocols. FORT again, only 16 to 22 millimeter value follicle per AFC. But in anticycles, commonly you'll get oocytes of 13 to 15 millimeter as well. So FORT is not going to be one of the great predictors, though it's a good gross monitor of an ability of your cycles. The limitations is we cannot track each follicle individually. I hope AI or some image modality, I think Philips has introduced this modality, that's what I've heard, that you touch the follicle on the screen and automatically the size of the follicle comes in. Because it's very difficult to measure all those follicles. I hope this technology gets very popular and very common to all of us, then we'll be able to track the follicle. May not be individually, but at least grossly, I would say, and possible, and because there could be a possible difference in FSH-driven growth amongst the follicle herd which is getting stimulated. So there is much more to explore, and technology needs to help us further. So the question is, shall we synchronize all our women in anti-protocol because the studies are anagonist synchronized? But if we try to synchronize an anti-protocol by using, let's say, agonist stop protocol or something, extreme responders will suffer more. Like an extreme responder could be a very low ovarian reserve. You're suppressing her pituitary ovarian axis further and telling it to awaken. I see a lot of people using agonist stop. I'm not saying anything wrong with that. But agonist stop protocol for somebody who has an AMH of 0.4 and FSH of 14, and somebody who has an AMH of 1 and FSH of 5 perform completely differently. So you'll have to individualize who will go into these kinds of synchronization. Again, when you have a patient of a high AMH or a high LH or a high AFC or a high BMI, an appropriate dose increases are needed. So we cannot have a generalized statement, let's synchronize everybody. PCOS, the problem of OHSs in PCOS has completely vanished. The common problem is low follicle output rate. And FORT is inversely related to AMH. Only 20% of high AMH have high FORT. I think this sentence has come out of the agonist studies and of all the studies published, which are only on 150 to 225 IU. So here I always quote two studies. One study by DeVos et al., wherein he's published a study by giving 150 to 225 IU, did HCG trigger, did fresh embryo transfer and frozen for the rest of the embryos and transfer frozen later. And he said the PCOS phenotype decreases the pregnancy rate because if it is highly androgenic, it will not do well. I think Sherry Nickens, she published another study, I think 2-3 years later, I think that was 2019, and Sherry Nickens published in 21-22. She published a study across all phenotype of PCOS, just gave a high dose. And in spite of the phenotype, it wouldn't matter. In every phenotype, she obtained 20 oocytes, and obviously the result cycle works. So I think this particular thing that FORT is inversely to AMH, and that is basically if you use a low dose. If you use a high dose and agonist trigger, not do a fresh embryo transfer, I don't think it would make much difference. So AMH does offer, it is a dualistic thing, and a high LH in PCOS could also arrest follicles. What happens with high LHs? The PCOS follicles develop LH receptors at just 4 to 6 millimeter. Now your high LH goes and attacks them, and cyclic AMP pathway is triggered. It will trigger ERK1, ERK2 as in surge, but also cyclic AMP, and that is going to mature the follicle. So another 2 divisions and the follicle gets arrested. So the follicle may just grow in size, but doesn't give an oocyte to you. While it's a diminished ovarian reserve women who are low AMH and they have low threshold and faster growth of follicle will be seen. So AFC, AMH, FSS are static biomarkers of response, and we need a dynamic marker on the go to assess the hypo response, and that could be FORT, but we need to dissect it further. What about follicle to oocyte index? The ratio of total number of oocyte number to the AFC, the start of stimulation, and again, this depends on your trigger, also your pickup, way you do pickup, etc. But it's a great marker from the Posidon point of view. Low AFC will always have a high FORT because there is no resistance and you will stimulate them very well. While high AFC can suffer having with a high FORT, and you need to appropriately give dosages. Number of oocytes and embryos increase from low to high FORT in respect to the age. When you have a high FORT, obviously your results are going to be better. You're going to have more top quality embryos, and obviously the pregnancy rates will be there. So can we do some pre-treatment to improve FORT or FOI? And these are the pre-treatment. I'm not going to talk in detail, just one slider, that some RCTs of testosterone pre-treatment, they say that increase the oocyte complexes, right, 4 by 1.5. And Sabira et al., they did 56 days of testosterone stimulation pre-treatment, and they had and 10 days, they had two groups, and they did not see any improvement. And even T-transport trial, they prolonged pre-treatment has no improvement. So there are so many trials published, more systematic reviews than RCTs in testosterone therapy. And they say that few of them do say there is an increased COC. But then a lot of them say there is no increased FOT or no increased oocyte output. So it is a short-term testosterone may be good, but a long-term testosterone has not improved result like your Nicholas Paulizo's trials. So certain individualized threshold of testosterone is needed. So a certain amount of testosterone is good. It provides a substrate. It pushes more primordial ahead. But a certain amount of testosterone is definitely inhibiting folliculogenesis. And we really don't know what is the individual cutoff of that testosterone. So practically in my practice, I've stopped using androgels in all our women. What about estradiol pre-treatment? Again, both sides of the story. There are a few studies like put in yellow that says no increase in oocyte soft-10. Even Sedin-Doran study says no increase in oocyte. Well, Franchin-Horan study, they had more metaphase 2 oocytes, better synchrony. There was a review article published that said more oocytes than this. I think this is one of the pre-treatments commonly practiced by all of us because it gives a good LH pool. It allows us to schedule cycles. It's something which is practiced by consensus world over, like a lot of European clinics who are scheduling each and every of their patient because they don't want to do a pickup on Saturday, Sunday, they are using estradiol valid treatment. I'm not going to speak on growth hormone. Only one thing is, I think we need to look into the growth hormone IGF levels before we give a therapy of growth hormone. Because if you give excess growth hormone and IGF level goes up, there's a possibility of an insulin resistance at the embryo level, and that can lead to miscarriage. So a nice study by Norbert Gleacher has been published on that regard. But women with a very low ovarian reserve may just have 1 to 3 oocytes. So what pre-treatment anyway will work? So it doesn't make any difference. So one important parameter of success in low ovarian reserve patient is going to be how many cycles you cancel. Because if you cancel a cycle, that's your failure. And the patient is going to take a failure. They're going to say, well, doctor, you did not give us a correct dosages or correct duration or correct therapy. So I think cancellation of cycle will be taken by the patient as failure. And you're looking at as a scientific error. But I think for patient, it is 0% or 100%. For us, it is different percentages. So ongoing stimulation, if you have just 2 follicles developing out of 20 AFC, probably you will cancel. But you have 2 follicles developing out of 4 AFC, well, you will not. So it's highly individualized thing. Again, this paper clearly says that if you have endometriosis, it will reduce the ovarian response in controlled ovarian stimulation independent of AMH, AFC, and woman's age, just because she has endometriosis. And they did a trial of endometriosis plus and endometriosis negative patient and look at the parameters, the 4 2-site, metaphase 2 sites, and fertility all suffered when there was endometriosis. While in the endometriosis new patients, they did progress very well. So I feel when it comes to low ovarian reserve women, AMH is a global marker. AFC is a local marker. So we all go by the AFC more than the AMH when we stimulate our low ovarian reserve patients. What about unexplained infertility, follicle output rate in unexplained infertility? So they had division. They did a percentile division of low FOT, moderate, and high FOT. And anyway, whichever patient had high FOT obviously had a better success rate. So it's an objective assessment. So we need to define poor responder based on FOT. And that will be very realistic definition for all of us. So how the clinical AMH and follicle output rate say, whenever you have low AMH, that means the resistance to FSH is hardly there. The smallest of the dose of FSH is going to start the follicular growth and you will get a good FOT. Or low AMH is high FOT. It's a high AMH. Only if you give an appropriate high dose, you can have a high FOT, otherwise not. So what could be the newer modalities? Stepping up the FSH dose halfway in controlled ovarian stimulation, but that will increase our synchrony. Can we use a step down of high dose? Let's start with 300, 450 IU and step down to 295 IU. So which actually a physiological thing, but not many studies onto this regard. Richard Fleming did something in 2023. He published that he gave FSH doses 12 hourly for first 2 days and then in high AMH women. So he took it very high, broke the AMH threshold and went ahead and stimulated and then they took the dose down. And he implemented, not many of us are doing this. And Barbara Lawrence and Human Fatemi, they rather stepped down. They said, once the follicle is 14 and 15 millimeter, it depends on LH. So it doesn't need so much of FSH. They cut down on the dose. They came under dose. So what happened? The follicle kept on growing because of the LH activity. The E2 levels did not go up high. The progesterone was not high. They said if you want to do a fresh embryo transfer, then this could be one mechanism it could work. But both these Richard Fleming and Barbara Lawrence study do not have any replicated studies. So only sporadic studies, and we may not be able to follow it very perfectly. So clinical implications, we are awaiting data on adjuvants and diminished ovarian reserve, which one will actually increase FORT, which stimulation regimen will increase FORT, less data on antagonist cycle and FORT studies, and Indian research is definitely needed onto this particular thing. Yeah, in this slide, I just want to put on the middle line, low FOI, less than 50%, was completely decided by Poseidon group arbitrarily and may not be relevant in all subgroups. So we need to have another parameter. These could be the parameters. This has been proposed by Shei Shankara in a paper of success parameters, beautifully published in 2023. So there's an early FORT. So number of follicles of beyond 10 millimeter on day 6 contribute to AFC. I think most of us are having fellows. If a fellow is stimulating the follicle, an early FORT will tell us whether the fellow has judged the patient properly. Have they started the dose correctly? Well, that will be one good indicator of picking up the low FORT. That will be one good indicator assessing a clinical KPI in our practice. Early assessment of dose response, in-cycle dose adjustment could be possible. Early decision to segment the cycle. If you have a hyper response, you can go for a freeze-all, etc. And then you can have a modified FORT, which I was telling you earlier, that you look at the antral follicle counts, follicles beyond 12 millimeter to AFC. Because every follicle beyond 12 millimeter has a potential of getting a oocyte in antagonist cycle, and that could be a modified FORT study. So if there is an AMH and AFC discordance, who stands tall? I think it comes to endometriosis, AFC, but otherwise AMH stands tall. That's what the study says. And the higher and lower AMH in relation to AFC may be due to up and down regulation of AMH secretion from the follicles. High AMH than the predicted AFC, that predicted could be PCOS because every follicle secretes more AMH, younger patient. Obviously, you'll get better blast provided you use appropriate dosages. Low AMH than predicted by the AFC, they'll be commonly seen at higher age and less favorable for ART outcome. So AMH overall is a robust marker. Yeah. So most of modern day predictors of IVF success are FORT, early FORT, modified FORT, FOI, ovarian sensitivity index. They are all available either during the stimulation or after completion one IVF cycle. And we still highly depend upon our traditional markers of AMH, age, BMI to start the first IVF stimulation. I looked at the PubMed on FOI and freeze-all Thaw cycle transfer. Any papers onto this? I just put follicle output index, oocyte index relationship, frozen embryo transfer cycle, no results. So there is lack of data on this particular thing. Thank you so much, all of you, for allowing me an adequate time to present my this, and all the discussion is welcome. Thank you very much, Anuradha madam and Seema madam, for extending this opportunity.
Thank you, sir. Thank you for such a wonderful presentation. Now we are open for discussions. Dr. Rohit.
Hi.
Yeah.
So wonderful as usual. And you've given us new insights about the practical aspect of looking at FORT and everything. I wouldn't have any comments to say other than why not, going by what you've suggested, why not have a standardized dose of 300 for all our patients?
Yeah, absolutely. So true. So true. Dr. Goody, would you sync with that? 300 IU, because you are in London, you see mixed ethnicity compared to what we see in India.
No, I would not. I think under experienced eyes, it is good. But when you have to remember, there are a lot of doctors around who are not very experienced treating PCOS. Now, if you step down from 300 to 150, it makes sense. But in some cases of PCOS, where in India they'll use recombinant more than HMG because of to avoid a batch-to-batch variation, you will see a huge response. Now, many Indian women have, unlike a Caucasian woman, will have a shorter abdominal length, which basically means that the ovaries with bad PCOS head towards becoming an abdominal organ and run the risk of having a compartment syndrome. And they go into very bad ovarian hyperstimulation even with an analog trigger. I've had that years ago, and I think it's good to be careful. I would rather say start with a dose of 300 if you want as a step down. But equally, you have to look at what PCOS you want to stimulate. PCOS which have a follicle count which is 4 to 6 millimeter don't require 300. They will go with 150 because these women are probably type C or type D type of phenotype, and they tend to respond very well. And those which are smaller and who have a very high testosterone, which are A and B, tend to do better with a step down regime rather than going with a with a continuous. So I'll say, for experienced hands, start with 300. Inexperienced or new doctors, be a bit cautious.
But Anil, just want to know, like you get this typical PCO who has a rosary pattern, all the follicles are less than 4 millimeter, and AMH is beyond 10 nanograms. LH is also hovering around 15, 20. How do you actually do your step down? I would like to know the steps of your step down protocol. What's the starting dose? When you step down, how much you step down? Well, we are not practicing step down very commonly, and that would be a great advice to us.
I think one of the things I always try and find out is that what is the level of insulin resistance? And the insulin resistance, to a large extent, AMH doesn't tell you much about insulin resistance. Ovarian volume tells you a lot more, LH tells you a lot more, and the androgens tell you a lot more. So in ovaries of large volume, or ovaries with a high LH and ovaries with high androgens, you're going to face a big challenge to a step-up regime. And my general plan is, if I see somebody with a high LH levels, I tend to tell them at least for 6 weeks, don't rush into treatment, because these are exactly the same women who will give you poor quality of blastocysts, which will have poor egg to follicle ratio. And what you're effectively then trying to ask people, why did my cycle not go well? Because there are extremes of the two. So poor responders and PCOS both do quite badly. And I'll say six weeks, take your myoinositol, maybe take metformin, try and see if you can get you a more regular pattern of your period, because irregular periods is the most best sign of insulin resistance. Those cases, I normally start with recombinant initially for 3 to 4 days, and I scan on day 5. I scan very early. I do all my scans, so it's to a large extent I tend to understand which ovary would go. So after 5 days, I step down to about 150. Now in PCOS, where I feel that it is going to be a very aggressive response, I do only 3 days of 300 and then move on to HMG. HMG, I believe, is a much better drug for PCOS than.
So you say 300 IU of Gonalef and then 150 Menopure for the rest of the cycle. Am I right?
That is for follicles which are of good sizes, 300 of HMG and 150, except for those where you see very small follicles, large ovaries, large LH, high AMH. In those cases, I do 5 days of 300 of recombinant and then 150 of. But all my cases go on to 14 days of letrozole. For 2 reasons. One is they become less symptomatic. Second, artificially, those estrogen levels are kept lower. Nick Macron's paper said that it increased the egg number by 1 or 2 on a gross scale. So I'll say, what do you lose? You lose nothing. As long as you don't look at the E2 and say it's a low E2, let me give them HCG, then it's a disaster. But otherwise, it gives you beautiful results. All my PCOs go on to 5 milligram of letrozole through the cycle, whatever stimulation regime I try. And post egg collection, I continue letrozole for 7 more days. The reason is that it keeps your peripheral estrogen levels low. Your risk of having bad ovarian hyperstimulation tend to be worse. I give the antagonist for another 5 days, and I debate upon giving carbagoline. People say carbagoline doesn't work in analog trigger. They are wrong, and this research shows that if you combine carbagoline and if you combine antagonist on an agonist trigger, the recovery rate is 30% faster.
Yeah, but Anil, you look at the research which is published on concomitant letrozole therapy to be given in ovarian stimulation, and the research comes from somebody like you who has been given for PCOS with an intention of keeping OHSS under control and all the side effects of hyperestrogenism under control, or even a delayed thrombogenicity that also is prevented by letrozole. And the research which is coming from the cancer patients, the breast cancer, all the systematic reviews published, is that if you keep your estrogen levels low, which is a mitogenic hormone, and your oocyte morphology does suffer. There are very interesting papers and research published onto that.
I will argue on that. Now, in your PCOS, what do you want? You want to have you want to break that cycle of androgen excess. Letrozole does that much better, and so from a physiological aspect, it should work. Now, if you look at
how does letrozole manage androgen excess? I don't think so. It will increase the intra-ovarian androgen. So how does it manage? Because I'm not worried about peripheral androgens. If I'm using a high dose,
letrozole. The reason why letrozole to a large extent works better than clomiphene is because it increases intrafollicular androgens, makes the follicles more sensitive. So you use exactly the same logic of giving it in PCOS, where you're just out of all the meta-analysis, adding letrozole seems to be beneficial in a PCOS case. So I've not.
I do agree. A lot of people like you are giving this hint to us on the crowd that the definite, and we go tend to follow that up. But if you look at the Bullau papers, she's been continuously publishing for the last 7-8 years on usage of letrozole and normal responders, poor responders, and PCOS. They categorically are taking the PCOS out of it. I think we need to just maybe do a short study or something to know, or maybe the study may not prove anything because the PCOS just has so many eggs and so many blastoses. So the pregnancy rate wouldn't matter much anyway. So I don't think it would matter much. I don't know how, it's an argument which may not stand or cannot be proven anyway.
I have a question here. A long time back, we had this discussion about using letrozole throughout the cycle, throughout the stimulation, and we were talking about decrement in intrafollicular estradiol level as it is going aromatase inhibitor, and that takes its toll on the oocyte morphology. It's true that we have a lot of oocytes here, and we are not worried about that blastocyst we'll be getting for the pregnancy, but does it not affect the quality of the blastocyst or oocyte M2? I would like to know from Anil.
I think
during stimulation.
I think the problem with in PCOS getting poor quality blastocysts is because of PCOS. It's nothing to do with letrozole.
Okay. Yeah, Grant,
I think we sometimes blame the drug. It is PCOS is a bad condition. It causes in metabolic PCOS. It is well known that mitochondrial function is affected and blastocyst conversion is quite poor. So somebody with very irregular periods. So I don't think letrozole really makes a difference. I use letrozole not because it improves quality, because it lowers symptoms. My role is slightly different. I like to have women complaining less.
Yes. For this very same reason, I also want to use just to decrease the symptoms. But that was the debate we were having, and Sachin sir was of opinion that letrozole could affect the oocyte quality, and that's why I wanted to understand it better. Thank you.
If it affects oocyte quality, then why is it given as an ovulation induction agent?
Exactly my point.
So if in fact it proves that as an ovulation induction agent, it beats clomiphene and comes close to FSH. So I think it's probably good.
I agree. We conjure with you. You're right.
Yeah, and especially with the extended protocols which we are using in many resistant to PCOS, we are using extended letrozoles, but they do get pregnant. I mean,
Yeah,
In
I think so.
IUIs, I'm talking
Yeah,
about.
I think given all the data, I use a lot of step down, what is not step up?
Stair step.
A stair-step protocol of letrozole, and I think results are brilliant. I think
Yes.
it's I think it works quite well. I would normally say if you look after the PCOS slightly differently, you're more likely to get a better quality of eggs, which means sometimes it takes 3 to 4 months of treating PCOS before you start their stimulation. I've recently seen somebody who's an AMH of 102, and I'm trying my best not to treat her because I keep telling her that there are other doctors better than me in this case, because whatever we do, it's going to be a nightmare. And why do we do IVF? So that we can sleep well at night. Anything that prevents you from sleeping well at night, you should let your competitor take it.
I would like to.
One word about step down.
Yeah, Dr. Manisha.
Sir, one word about step down. Hi, sir. Good evening, sir. Such an excellent lecture. Sir, one word about step down. We are using that protocol. We are using a software which is known as Opt IVF. So what we do is we start with 225, and after 6 days, we go on decreasing the dose till we come on trigger day, and the dose is we don't give probably trigger the dose for 1 or 2 days. We used to use 300, 375, 450 for our poor responder patients, but ever since we have started this protocol, we are decreasing the dose, we are getting better number of eggs. For low reserve, we are talking about people who have AMH of 0.2, 0.3, 0.4, and we are getting good number of eggs, and we trigger at 12 to 13, and we are still getting M2s. So we are following that low dose protocol where we go down. What we have seen in this category of patient where the reserve is very low, the protocol does well. So does the PCOS. In PCOS also, we are seeing that though the number which we are expecting is less, but still we are getting better number of follicles and less the OHSs. So nowadays we hardly see, sir. But especially in cases of severe PCOS where AMH is like 15 to 20, we are seeing better response.
Manisha,
We've started from last 6 months.
Manisha, one thing I couldn't get, why are you triggering them on 12 and 13 millimeter?
Yeah, ma'am. So we take this software which is known as Opt IVF, and we give the dose for 6 days. At 6 day, we again do the scan, and the software will tell us when to trigger the patient. So the days will come. So at 10th day, if they say the trigger is come, so at that day no dose is given, and if the follicle size is 13, 12, 13, 14, we trigger. And ma'am, we were very apprehensive because I am one of those doctors who used to give like 14 days stimulation, 15 days stimulation. But with this protocol, we have seen that triggering at 13 to 14 also gives us M2, and especially in these poor responder patients.
Well, just one small thing. Just allow me to leave. I need to catch a flight. Anil, thank you so much. Rohit sir, thank you
So
very
much,
much.
sir.
Thank you.
You so much,
Happy
Dr.
journey,
Sachin.
sir. Happy journey, sir.
Yeah, so bye.
I don't know.
So,
I'm
ma'am,
not convinced to trigger at 12 or 13. Dr.
sounds
Anil,
like
what
in
is your
vitro.
take?
It sounds like
I'm
in
not
vitro
convinced, Dr.
maturation.
Anil. You have something to share.
I know, ma'am.
Triggering at 12 to 13.
I know, ma'am. I agree. So that is. So,
I
ma'am,
remember
this is what they
that
said when
trigger
we
is
started.
given
We
for
were one of those.
IVM, in vitro maturation. That trigger is given probably. There
So,
also you wait
I
for
know,
1
ma'am,
or 2
and
days.
we were just not convinced. So, ma'am, we were just not convinced, and this is what the protocol taught us, that we were like, "Ki, we will not give trigger." So they were like, "Okay, wait for one more day. If you really are not convinced to give trigger at this day, what the Opt IVF tell you." But, ma'am, we were doing it because earlier we were following the normal protocol where we used to give trigger at 16 to 18. But with Opt, we have realized that we get M2s also, and we are forming blastocyst.
Should we take opinion of others on this, Dr. Rohit?
I'm aware of this software per se, but as a practice, I think, and professor is there, he will concur that in PCO we trigger a little late, and in the older women we trigger a little early. So it all depends on which kind of patient profile we are talking about. If Dr. Manisha is talking about slightly elderly age group, 35 plus, in those cases maybe a 15, 16 trigger also works. I'm just kind of
Yes, sir.
trying to guess, but this sounds a little more radical to trigger at 20, 12, 13. So.
Dr.
Yeah.
Anil, what's your opinion on this?
I think the data is quite a huge data that over 16 millimeter, about 60 to 70% of follicles may contain eggs. Between 12 and 14, around 30% of follicles contain eggs. That's what the data is. I always believe that, sometimes you aspirate a 13 millimeter follicle, you may get an egg. And I'm not saying you won't get an egg. You may get an egg, and sometimes you'll get a mature egg. And the best way to test those eggs from a smaller follicle is to get them to a blastocyst stage. There is good evidence that smaller follicles that give mature eggs do not have cytoplasmic maturity, and often they don't get to a blastocyst stage. So we often opt out by doing a day 3 transfer. A day 3 transfer, I call it, is an easy way out because it doesn't answer those questions. Now, I've done about 3 talks on size of follicles and maturity, and the data is quite good on indicating that if your follicle size is less than 14, your chance of getting a mature eggs is less, unless you're doing IVM and maturing outside.
That's what, sir, when we've been taught and we've been practicing, like for IVM, you can trigger at 13 or 14. But anyway, I think, Manisha, you should collect the data and make a paper and present it. I mean, it's
We
an
are collecting the
eye-opener
data.
for us.
Yes.
Yeah,
We are
do
doing it,
present
ma'am.
it. We'll
In
invite you
fact,
for a
Ma'am,
conference, please. Yeah.
in
Yes,
fact,
we
I
are
was thinking about
collecting the data.
asking. In fact, I was thinking about asking the choice of follicular size as per the trigger, as in agonist cycle and agonist trigger and SCG trigger. Are you guys doing the same size of follicles for both, or different size criteria for
Yes,
both?
ma'am. Ma'am, generally we give dual trigger for them, for these patients. And we trigger at around 30. Ma'am, see, this is what I'm saying, the dosing chart comes.
Poor ovarian reserve patients? Poor
Yeah,
ovarian
she's
Ma'am,
doing
reserve
it for poor ovarian.
yes, sir, poor ovarian reserve.
Okay.
Poor
Only
ovarian reserve, ma'am.
for those
Yeah, ma'am.
patients, you are following that software, and it can tell
No,
you
not for
that you.
everybody we are following. But then what we are seeing,
Okay.
I'm talking about the poor one. Obviously, dual, not for ma'am,
No. I
the
am also using
people.
dual for everyone. I'm not talking about that. I am asking
Uh,
you, is this software telling to trigger almost every patient at around 12 to 14?
no, ma'am. It is not telling you to trigger at 12 to 14.
Hmm.
So what happens is you give 6 days of stimulation, then you do your software tells you that whether you continue the same dose or you go on decreasing the dose. But in 80% of the cases, the dose goes down. So by 10th or 11th day, the final dose of trigger is shown. So you do your scans and you see how much is how the growth is. But what I'm saying is that we have triggered at 14 days, like at 10 days, if they tell you that to trigger the patient, we do the scan and we have seen follicles of the size 13 to 14, and we have got mature oocyte in them also. Because ma'am, we were under the concept that you will not get a mature oocyte at unless the size of the follicle is around 16 17 millimeter. But with this protocol, we have seen that we are getting mature oocyte even at 13 14 millimeter also.
Rohit, what
And
is
this,
your criteria? How are you doing it? Triggers, size, you're following something, or same or for everyone?
I'm quite
ma'am,
intrigued with what Dr. Manisha mentioned. For me, right now, it's a very standard practice. If it's a PCO, then it's triggered between 18 to 20. If it's a donor, then it's a trigger between 18 to 20. And if it is a poor responder, Poseidon 4, then it's a trigger at 16 to 18. So that is what I do.
How
And
are
you
you?
use dual trigger, no, Dr. Rohit,
Yeah,
for poor
Yeah,
responders,
that's
or
tough.
or you
unfortunately,
use only HCG?
no, unfortunately, now I'm spiking everyone with a little bit of HCG. I wouldn't call it a dual trigger. It will be like some amount of HCG and agonist. The reason
Sliding
is more,
scale.
yeah, its reason is more practical rather than any esoteric theory here. I have seen some patients not responding to the agonist because of the patients on the pills and so on and so forth. So just to be on the safe side, except for the donors where the LH levels are good, everyone else is on some amount of HCG.
So should we move on, Dr. Seema?
Just one comment from Anil sir about his idea about the triggering.
I'm generally very pro agonist trigger on all over responders. For PCOS, where smaller follicles, I think there is no going back. I weigh on it and say, what is more important? A patient leaving you because you've given them a bad result, or a patient in ITU? And I think I've come to a stage in my life that I've stopped thinking I'm a hero. I really don't want to get a heart attack this soon. So I do an analog trigger. I always check my analog trigger. So in the morning, I'll either ask them to pee on a stick to show an LH test positive, but I always get blood tests done. And I agree that there's some women, I don't know why, who are not slim, who are not on the pill, who don't seem to do very well with the analog trigger. I just don't know why it happens. I've recently had somebody who I gave an analog trigger, completely normal BMI, everything normal. She got 6 out of 20 follicles, 6 eggs. And next time I gave her 2000 of HCG and got 18 out of 20. So clearly, whenever analog was used, I don't know which women it happens, because the challenge which you have is, are they not creating a cumulus complex with an LH rise? I remember the LH rise in an analog trigger is quite shorter. It doesn't mimic nature. So you can't replicate it in nature. So I don't know. I just don't know. But some women don't seem to trigger very well. So I think if you are slightly confused, giving a small tickle of HCG of what Rohit does is not a bad idea. But don't do it in PCOS where you got 40 follicles.
How much HCG do you give, Dr. Rohit?
It's sort of a sliding scale. It's a sort of a sliding scale that I've invented from
Please
75.
tell your invention, na? We will also,
From 75 to 250, depending on the number of eggs. So if it's like a 20 follicle thing, then it's 75 IU, and then you go up the ladder as the number of eggs decrease.
Okay.
So that's what I'm asking. Suppose her LH is less than 1 on the day of trigger. She's a PCOS, she's got 30 follicles. And will your agonist trigger work in this patient?
Yeah, and a follow-up question on that also to Professor as well, is that does PPOS not agree that well with agonist trigger? Because I've seen this more happening with the PPOS control, where the agonist trigger somehow does not work that well. Is it because the LH is far lower in the PPOS control? Is that something to do with it?
Rohit, I am using this SCG on sliding scale, and you are right that these patients on MPA via PPOS patients, donors, most of the time I'm keeping them on PPOS, and their LH I am getting 0.8, 0.7.
Yeah, exactly.
Yeah. So I have to, if I don't give them this, no use of those eggs. I tried, but it didn't work. So I started using this SCG on sliding scale, even in PCOS, even if it is 1000 into urinary, or if I am going on recombinant, so I divide it into 4 and all those things, as you have mentioned.
Perfect.
Should we move on now? Yeah. So our next speaker is Dr. Anil Gudi, and we move on to the session 2. And the topic is strategizing ovarian stimulation protocols in extreme poor ovarian reserve. Experts are Dr. Pratik Tambe, Dr. Manisha, Dr. Vandana, and myself. Can we display Dr. Anil's CV? Dr. Anil, I have made little bit, not too much, your CV. Please allow us. Darshan, can you
Yes, ma'am.
display
Yes,
the
ma'am.
CV, please? Dr. Anil's? Very short, sir, as per your Dr. Anil Goodi's CV. Yeah. So Dr. Anil Goody, he's based in London, England, and he's qualified his degree in 90. He was admitted as a full-time member of RCOG and in 99 and became a qualified consultant in 2005. Mr. Goody trained in the field of fertility medicine and carried out extensive research at Bombay Hospital, India and Homerton Hospital in London. He has been HFEA person responsible and lead clinician at Homerton Fertility Center over last 4 years. He specializes in assisted conception techniques, fertility preserving, keyhole surgeries, endometriosis, and patients of PCOS and all, as he was saying, he gets these patients. So he is also at the London Fertility Center and Spire Roading Hospital. So welcome, sir. The next expert is Dr. Pratik Tambe. Please display quickly. I'll just, because we are, yeah, he's IVF consultant and gynec endoscopic surgeon from Mumbai. And he is at present governing council member of ICOG. He is also an executive member managing committee of
I think we're
ISAR.
good. We're good.
Yeah.
Thank you, Dr. Anuradha.
So thank you,
Let's
Dr.
get on with
Pratik.
the talk.
And he's a very good academician and a good friend. Okay. Next is Dr. Vandana. She's from, okay. Dr. Manisha Vandana, yeah. Dr. Vandana Hegde, she is a consultant at Hegde Fertility Center in Hyderabad, and she has received a lot of awards, and she has been a fantastic student. So welcome. Dr. Manisha Bhagat. Yeah. Dr. Manisha is works with the Indra IVF Center in Jammu, and because I also belong to J&K, so that's the link we have. She has received a lot of awards, Jeevan Jyoti and FNB Reproductive Medicine. She has done in 2013, presented a lot of lectures and papers. So welcome all, and Dr. Anil, now you can start your slide sharing.
Okay. I think y'all need to give me access. I can't.
Mr.
share.
Darshan?
Yes, ma'am. Access is already
Sir is
given.
not able to
Just a
share.
second.
Kindly enable. Yeah. Screen share. Yeah.
Now, sir, are you able to share the screen?
No, for some reason I'm not, but let me check. Let me sign out and come back and see. Just 1 minute.
Okay.
We are expecting a lot of participation from our viewers as well, and people who have joined through this link on Zoom. Please feel free to question and give your opinions as well. That's why we are here today. It's totally for academic purposes, and please contribute and share your views as well.
Dr. Vandana, are you there?
Yeah.
Dr. Vandana is using lot of PPOS protocols. So what is your take on PPOS stimulation protocol and the triggers given? There was a debate on that just now. Yeah.
Yeah. The PPO is what I feel is what I started with is medroxyprogesterone acetate. After that, I did switch over to dydrogesterone. So there, I don't see that much, decrease in the LH values at trigger. And we routinely give agonist protocol, but we do check their LH levels. And if we feel the BMI is more or the number of follicles are more, then we just give a double trigger. So after 12 hours, we just draw the patient's LH for blood. At the same time, we give 2 more agonists.
So,
We keep it safe. Yeah.
Vandana, 2 questions from my side. One is, any particular reason, was it LS over LS suppression why you switched over to dydrogesterone?
Actually, what I felt is giving medroxyprogesterone acetate was little hampering our endometrium in the next cycle. giving, continuous medroxy for that 30 days of the cycle.
But
And the
I don't
dydrogesterone is
know,
a
but
more,
I have not felt so. Yeah, but
you're giving
somehow I didn't
medroxyprogesterone in
feel.
PPOS?
I didn't feel that in next cycle at all. And
Okay.
second question that if your LH at the time of trigger is less than 1, baseline
Yes.
LH activity is not there. It's been established that this particular patient, even if you repeat the agonist, will not behave as it should be. So
Yeah,
the
that is.
answer is SCG.
I
And that's
don't
why.
see patients with less than LH1 in patients who have
Okay.
switched over to dydrogesterone. That's what I would say. Where they switch
So
from
therefore,
medroxy to dydrogesterone,
let's
I feel
compare.
that there is a difference.
Let's compare. This thing is very interesting, and we can come out with something. We'll talk later.
Yeah. Regarding that
The
early trigger, no?
medroxyprogesterone is a stronger progesterone.
Yes.
Probably the LH goes very low in these patients, and that is why now a lot of people have moved over to the dydrogesterone. So, are you ready? Yeah.
Yes. Okay.
We can see, sir. Okay.
Sir, I
is
think you're
muted.
muted. You'll need to unmute, please.
Anyway, Dr. Kar and Seema, thank you very much for getting me on here. For some reason, I'd forgotten it in the morning till I saw a message, and then I had to get back. So I got back in time. So can poor responders be treated effectively? So these are all the treatments for poor responders. And you can see that there are lots of treatments for poor responders. Whenever they have lots of treatment for poor responders, it basically means that we really don't know what really helps in poor responders. And that's where research is effectively there. Now, if you look at the techniques of, a poor responder, let me just. If you look at the techniques, you could have done multiple techniques of mild stimulation, natural IVF, and think what you want. Nothing seems to really work. People have tried DHEA. Does it improve follicle count? It does to a large extent. But the research it was based on had to be abandoned because everyone started taking DHEA. So again, we don't know how much of that works. So RCT was cancelled. Look at testosterone. Giving priming, again, the evidence was quite limited. Look at the letrozole antagonist microdose. Think of a protocol. We haven't yet come across a protocol to suggest that this protocol is going to work. Adding LH, the logic was better oocytes, again, not been proved. Increasing FSH beyond 300, there is no evidence that it helps. Adding aspirin, Viagra, again, doesn't seem to work. Clomiphene in poor responders has been tried, and again, it doesn't seem to make much difference. People have used growth hormone, it's making a comeback, but again, the evidence suggests that growth hormone may not work. And people said, well, why don't we do natural IVF? If you look at the natural IVF, and this was based on a huge amount of data from the UK. And when you look at natural IVF, the chances of pregnancy for 2 decades was a live birth rate of 4%. And often I say, when you do natural IVF, I say you're often paying for my holidays or my trip abroad because, in effect, you're not going to get pregnant doing natural IVF. So one of the things which we have to understand is that oocyte quality and age are beyond repair. And sometimes patients don't really accept it because patients think, well, IVF is there. I may be 40 years old, but medicine will help me. And medicine doesn't. You cannot change oocyte quality. And there's no effective treatment for a poor responder. So if you ask me what is the best protocol, I'll say there is no such protocol. You can have 10 different conferences. And the baseline is that there is no protocol. So that's the truth. Now we'll say, well, you can't tell your patients there's no protocol, go home, and there's nothing I can do. So let's see what we can do. There's one thing you can do is you can lower female's age. So if you can make a woman younger, everything changes. Sadly, we don't have that. So how can we change the outcome? So let's go back and say, why is it that in women with a poor reserve, who have a low AMH, a low follicle count, why don't they get pregnant? One is because they've got less eggs. So can we increase the number of eggs? The data is that if you have more embryos to replace, pregnancy rates also go up. So very much, that is well known. Egg number and live birth rate. And again, the more the number of eggs you have, when you get between 8 and 12 eggs, you're more likely to have a better live birth. Once you cross, 20 eggs, the statistical rise of live birth rate doesn't start. Again, if you look at multiple studies, the general rule is if you can get between 6 and 12 eggs, your chance of pregnancy remains quite good. So, when you don't know what to do, you start classification. So the older criteria of the Bologna criteria was quite simple. You needed to have 2 of the 3 of either advanced maternal age, previous poor response, or a low AMH or an AFC. And that would give us an idea that, are you a poor responder? But that has since changed to Poseidon classification. Poseidon classification doesn't tell you what protocol you use. It just classifies which poor responder is likely to respond better and which poor responder is responding poorly, mainly because of our protocol. So Poseidon 1 are women who are young, and Poseidon 3 are women who are old. So there are 2 extremes of it. And so what does Poseidon 1 do? Poseidon 1 is younger women with an AFC which is decent, AMH which is decent, and there's an unexpected or a suboptimal ovarian response. Very common. And you see somebody with a good AMH, you give a dose of 450, you get 2 follicles. There's something going wrong. So sometimes you get more. 1A is less than 4 oocytes, and 1B is 4 to 9 oocytes. So if you look at number 3 is younger patient with a poor ovarian reserve. So they're both younger patients. But they have less number of follicles and less number of AMH. That's where you will see a response getting worse. Poseidon 2 is again older women with a good AMH and a good AFC, and Poseidon 4 is probably the worst older women with a poor ovarian reserve. So if you say which is the patient in which you will head very likely towards egg donation, and that's Poseidon 4. Which is a group where you'll have to have a serious think of your protocol, and that's Poseidon 1. And because your protocol is going wrong there. So it is a slightly more diagrammatic way of representing. Again, 1 and 3 younger women, 2 and 4 older women. 4 is probably the worst. So you see somebody who's 40 years old, AMH of, let's say 2p mole or 3p mole, and 4 follicles. You're going to struggle to achieve a pregnancy. So Poseidon again is patient-oriented strategies encompassing individualized oocyte number. So again, we've said this, 3 and 4 are generally the older women. So what are the challenges from Poseidon? It allows you to have some fine-tuning, low prognosis patients, we can identify them. It allows us to collect data better, and eventually you will be able to make some plans. Poseidon again doesn't tell you which protocol is the best. It gives you a better platform to collect data, but also it gives you a better way of looking at which patients may help. So what should be your strategy is the shortest time to a live birth and the lowest risk of complications. What we know is that poor ovarian reserve varies. And what is wrong with these patients is reduced number of follicles, reduced granular cell function, and reduced number of follicles responding to FSH. Again, as I said, Poseidon 1 is you have seen a low response in good reserve patient, and we start talking about polymorphism, or is it something we are missing? So if you don't want to use Poseidon, then I'll say use 2 different terminologies. One is classic low ovarian reserve, that is low reserve, low antral follicle count, expected poor response. Other is a hypo-responder. Never confuse poor response with somebody with a poor reserve. There are women who you start a protocol and you don't get a response, and you don't get a response which you want. And that is women with a normal ovarian reserve, unexpected suboptimal response, and a low follicular output rate. So in a poor response, you're looking at inadequate stimulation, or probably a wrong time to stimulate, or a wrong time when you have started stimulation. The poor response may not be to just inadequate FSH levels. Now, often, I don't know how many of you all measure FSH. I tend to measure FSH on all my patients during stimulation because it just gives you an idea if they're taking FSH correctly. In those women who respond very poorly, there seems to be a problem within the follicle. There seems to be a decreased sensitivity. And the way you'll know is that even with good number of follicles, you'll see a lower estrogen. Should you downregulate for poor responder? And the answer is whatever downregulation you use, it lowers the follicle count. It lowers the antral follicle count. So my general policy is that if somebody comes with a low AMH and a low AFC, I do not downregulate. And the data is quite decent in that group. Finally, as I said, the more blastocysts you have, better chance of getting a pregnancy. And if you look at one of the studies, we looked at euploid embryo. So number of blastocysts needed to achieve one euploid embryo at the age of 35, around 4 blastocysts. At the age of 45, 29 blastocysts. So you can just see that a patient at 45 is never going to get to a pregnancy. It's going to be very difficult. I've had patients at 43 and 44 who got to the 8th or the 9th cycle where eventually they've got a euploid blastocyst and have been pregnant. But that is a challenge which you have to tell your patients that as you get older, it's less likely you'll get. Number of oocytes, again, there's a data that suggested that you need between 40 and 42, 17 oocytes to get at least one euploid embryo. Again, it's the question of numbers, the more eggs you have. So where is your focus? If you want to help somebody with a low ovarian reserve, you need more oocytes. So how can we get more oocytes? So there is something known as, which I follow very often, is chasing the destiny, which is chasing the antral follicle. And that's not based on my theory. It's I as much as you have claimed that I've done a lot of things. It's not. I'm not such a bright person to come up with weird strategies. There is a very old study which tells us that follicular recruitment is a constant phenomena. And I can tell you, women who are young, not old, who are young, scan them every 10 days. And trust me, you'll see a different follicle count, unless somebody's got a high FSH and heading towards menopause. And follicle recruitment is not a constant phenomena. It is a wave phenomena. It is not a follicular-based phenomena only. Peak of the follicle varies. It's very simple that you need to find out where that peak of follicle rise. It's not just knowing how much to stimulate. It's not knowing with what you stimulate. In poor responders, it's knowing when to stimulate. It will change and give them some chance of a pregnancy. So if you look at this study, and this data comes from the 1980s, and what they found out was women will recruit at least twice in a menstrual cycle, but ovulate once. Animals tend to ovulate twice in a menstrual cycle, but humans don't. What was also seen that the luteal phase recruitment window was always wider than the follicular phase recruitment, which means that what happens in a luteal phase? In a luteal phase, your FSH and LH is low because that's how the luteal phase goes through. And that's again, when you give progesterone, you can sometimes subdue the LH. And I think Rohit was correct in that, is sometimes you end up, your analog trigger may not be working because your LH is generally low in the luteal phase, and giving progesterone can do that. So if you're in the luteal phase, your recruitment window is going to be much wider. So you will see a much better synchronous growth in a luteal phase stimulation. So before you go to the protocols, I'll say understanding a few things is some markers like the follicle to oocyte index, follicular output rate, number of antral follicles that respond to ovarian stimulation. If you have a lesser number of follicles respond, take a step back. Let's say you had 12 follicles and only 4 responded, think of your protocol. Rather than jumping onto the ovary and saying there's something wrong, your ovaries are not responding, there is, polymorphism. I rarely comment on polymorphism, but the question is, how do you diagnose it? Unless you want to make the patient spend so much, you talk to them about polymorphism, but otherwise you don't know. Total number of oocyte sensitivity index is total number of FSH dose and oocyte retrieved. That again tells you a lot more about how the ovary functions. Follicle to oocyte index, number of follicles at the end of stimulation, and how many eggs you get. So if you get a low number of eggs, you know that many of the follicles are remaining empty. Again, where does it happen? Happens in extreme low AMH and in older women. Why does a hypo-response occur? Multiple reasons. Low gonadotrophin dose, genetic factors, asynchronous growth, and technical issues. So again, as soon as you see a patient, you have to find out whether she's young and old. If she's old, you have to be very clear and say, see, are you ready to undergo multiple treatments? And it will take multiple treatments to maybe achieve a pregnancy. In younger women who have a low AMH, you may see and study whether their follicle count is going through a variation. So based on that, what treatments do you have? You have dual stimulation, you got luteal phase stimulation, and you got random start of stimulation. All very much proven by research. What is luteal phase stimulation? And is start stimulation in the luteal phase, where generally between day 24 to 28 of a 28-day cycle. Why? Because one, your FSH and LH are low, the luteal phase has a wider recruitment window, and follicles which are stimulated in the luteal phase don't tend to go through to premature ovulation. Why? Because many of the poor responders or women with low AMH tend to start having premature ovulation even on an antagonist protocol. But if you stimulate them before they start their period, you are less likely to have a spontaneous LH surge, and that has been proven through multiple studies. So when you compare a follicular phase to luteal phase, the chances of a live birth rate was very much the same. Where did they see the best chance of a live birth rate? In a mixed protocol, where you have done a random start and got a larger number of follicles. When you compare in donors again, day 2 to day 15, exactly same, no change in pregnancy rates. And what does it tell us is that the oocyte quality, irrespective when you stimulate, does not change. So what is dual stimulation? Do I do dual stimulation? I don't, except for in rare cases. Stimulate in the follicular phase, stimulate in the luteal phase, and avoid giving HCG in the first egg collection. So what it teaches us is that follicles are constantly recruited. In poor responders, some follicles may be of better quality at both stages. Do not drain small follicles at egg collection. Always give an analog trigger because HCG acts on smaller follicles. Luteal phase stimulation has been used adequately in cancer patients. And this was a paper in RBM Online. So what did he do? He stimulated with HMG, clomiphene, letrozole, and gave an analog trigger, collected eggs, then started stimulating again, collected eggs again. He got brilliant results. We have not been able to replicate them. So where do you see? So you see an ovary like this, where you have 3 large follicles and multiple small follicles. These follicles can be stimulated. Then you can do a dual stimulation, provided you see follicles. Here, don't trigger with HCG, trigger with an analog, collect eggs, and immediately start with stimulation of the ovaries the next day. And this was a paper that was presented in poor responders of first retrieval, 53% ongoing pregnancy rate, second, 57%. Sadly, no one's been able to replicate this study. So if tomorrow I tell you that I have got a 95% result, and then you come to my lecture, you see what protocol I do, and then you go home and do it. And then you say, I'm getting a 40% result. And how is he getting a 90%? So you have to question my 90%, not your 40%. Unless research which cannot be replicated, which by anyone, is always a suspicion. So if somebody says, I've got a 90% result, if follow his protocol, if it's not replicating, he's not getting a 90% result. That's a marketing stunt, which is very common. So when you looked at follicular phase and luteal phase, euploidy rates were again exactly the same. There's no difference between when you stimulate the patient. So let's come to now understanding. Now, what we know is that luteal phase stimulation works, random stimulation works, dual stimulation works. The patient says, hang on, can you do something? I've seen 10 different doctors and everybody has said egg donation. And I'll say, well, somebody's young. Let's try and understand what that ovary is doing. Do you want to give DHEA? Give it for whatever it's worth, because patients go online. And now, in fact, patients go on AI and find out. And I always ask you, one of the things which you should subscribe to if you want to remain in practice is to subscribe to Perplexity. Perplexity follows a different AI tool, and unlike ChatGPT and Grok or Gemini, Perplexity, I think, follows, it's called the raw model of going to studies where it gives you references. And always keep it open on your desktop, because the patient asks you that if I kick my husband on the balls, will his sperm count improve? Perplexity will give you the answer with references. And your patients will be doing exactly that. They won't go to Google now. They'll go to Gemini. They'll go to Perplexity. These are available at a fraction of the price. And they'll give you references which, even if you sit and read every day and out, you can't match it. So I keep it open. So my patients say, what a clever doctor. He knows everything. But do that. So you go back to this years ago, I used to call it the Goody Triangle. I named it Goody Triangle because all 4-letter words excite people, whatever 4-letter words you use. So AMH is low. You have to find out if there's a variable antral follicle count. If a woman has 2-3 follicles, scan every 10 to 15 days. And in some cases, for example, I had somebody who, after the 6th scan, showed 12 follicles which you could stimulate. Otherwise, there were 4 to 5 follicles. And sometimes you just have to wait that long. And that is the beauty of understanding the ovary. So in those cases, but some women have fixed antral follicle count. How do you know it? Small ovaries. Small ovaries with low theca, you'll never be able to see a variable antral follicle count. Again, remember, if you stimulate 5 follicles and you get 8 eggs, your scan was wrong. You can only stimulate follicles which you can see. Follicles which you can't see can't be stimulated. Stimulate again when the follicle count is the best. Have that patience. Again, look at the size of follicles. Follicles which are less than 4 millimeter rarely stimulate well. And they almost always either don't stimulate or form the second cohort. It's not so follicles which are larger tend to stimulate. Now, one of the things which you could do is don't start stimulation till day, if you're starting a period, till day 4. Why? Because as the FSH climbs, humans start with a multifollicular growth and eventually one follicle grows. So you allow time for those follicles to grow. What I tend to do is I tend to sometimes give 2 days or 3 days of clomiphene, because it gives you a slightly higher FSH, which may recruit a slightly larger number of follicles, and then a start stimulation. So it's that combination or combination which you can try. I tend to use clomiphene quite a lot. Why? Because clomiphene gives you FSH in pulsatile signals. Your recombinant or your HMB doesn't do that. Again, decide, when your follicle count is good. You get your junior to sit down and scan this woman every 7 to 10 days and see whether the follicle count gets better. And sometimes, like for example, this patient, you would say day 27, had a good follicle count, start stimulating. I don't give antagonists to knock out the corpus luteum. I don't do all those things. It doesn't really help. It's a waste of time. Start on a higher dose of 300 of recombinant. They often override the high LH. So you can decide, when, for example, there's a dominant follicle, start stimulating. Do not give HCG. Do not try and make her ovulate. Start stimulating. Follicles will respond. Again, the luteal phase is often, so, if you think that by day 23, 24, follicle counts are good, start stimulating. You'll see a much better recruitment. The challenge is sometimes you'll miss a pregnancy. Once in a while, pregnancies do happen, and they often don't come to any harm. Does adjusting the dose in poor responder help? The answer is no. Once you have lost the first few days, then you can do what you want. You can up the dose, lower the dose, you can add something, but your first cohort of follicles would have gone. Do maximum protocols work? Not really. It depends on the size of the follicles. If you have larger size follicles, mild stimulation may also work. They looked at poor responders who, this is not a random start, but they looked at mild and conventional. Results were very similar. Again, increasing dose of FSH does not reduce cancellation rates. Starting on a higher dose of FSH may help, but I tend to say, in all the evidence, the recombinant FSH in poor responders tends to recruit more follicles. There is no doubt about it. That's where I tend to use recombinant and then add HMG. Increasing dose in poor responders, low number of FSH sensitive follicles cannot be solved by increasing dose. FSH exposure is very much the same. And one way I'll say is always measure your FSH levels, because it gives you an idea if you're reaching an FSH of more than 20 when you stimulate. Maximum concentrations of FSH are achieved after 7 to 10 hours. And as soon as you give your first or second dose, by day 2 or day 3, you see an FSH of 15 to 20. Even after 24 hours, the maximum level of FSH is reached. And all this is in the follicular phase. And once you have lost that first 2 or 3 days, you really can't change how the follicles stimulate. One option is egg banking or embryo banking to build up the number of oocytes. We have over the years built up one of the best egg freezing protocols in embryology, which means we have a very low loss rate. And our egg banking has worked quite well. So if that's one of the things which you get your embryologist to do, is to fine-tune egg freezing, because it is cheaper than embryo banking. And if you can do that, results will be brilliant. Finally, stimulation does not change oocyte quality, and egg quality is beyond repair. So, yeah. So that's it. I don't know how to stop this because I tried something.
Thank you so much, sir. Now we are open for discussion. Dr. Pratik? Dr. Vandana? Yeah, Dr. Pratik?
Thank you, Mr. Godi. Fantastic presentation as always, and eye-opener to have a distinguished personality like you talking to us about poor responders. It's always wonderful to have a fresh perspective because of the wide variety of cases that you see. We don't see a lot of Caucasian patients in our practice, and I think you have the right mix of new protocols addressed during a presentation, as well as the different perspective from us Indian clinicians. So always wonderful to listen to you and learn from you. As you rightly mentioned, Poseidon gives us a very good foundation, gives us a nice framework, and we can only build on this. But to build on this, all of us need to collaborate. We need to put together our data. We need to share our experiences, and we need to learn from each other rather than think that we are competing with each other.
Dr. Manisha?
So, what is the starting dose generally you use for poor responders?
It goes
Say
to
for
the
a
follow.
female who is 40 years and her AMH is like 0.1 and her FSH is around 12.
I don't know. I don't work that way. I'm a great believer that age is a number, AMH is a number, and that's it. Your FSH, a high FSH, is more indicative that you're going to struggle to stimulate the ovaries, and so will always tell my patient that your high FSH is your body is trying to tell the ovary that I am struggling. And it is a woman's body, the pituitary, that's telling it. So I am a great believer that AMH was given. I have a story that gynecologist went to God and said, "Our practice is not doing well. Give me a hormone. Give me a hormone that will make me rich." So God said, "Go ahead. I'll give you a hormone known as AMH." AMH came, and all that AMH does is it scares women to the hell. It's a fantastic tool we've got. It will scare even any AMH. You tell a woman, she'll look at the chart and say, "My AMH is not that high. Oh, I'm getting old." You can convince any woman to do anything once you do her AMH. So the AMH, I think it's a waste. I don't use it as much. I tell women that AMH is your long-term reserve. It's like saying your savings are low, but you don't need your savings. You need your current account. Antral follicle count is your current account. So I'm a great believer that whatever be your AMH, let's have a look at your ovaries. Can your ovaries produce more follicles? If they can, I'll scan you. And if eventually your ovary doesn't give eggs, there's nothing I can do. I'll try my best. But I will try and find out if a woman's ovary is doing something different. Evidence suggests that women's ovaries do recruit in a variable manner. Whether or not we have the patience to do it is a different matter. You could decide. In my practice, I see 200 patients a day. And I can't do it that way. That's absolutely fine. But we know that women recruit in variable manner. So if you can recruit follicles, then it works. It may work. Not doesn't work. It may.
Yeah, Dr. Anil, very practical talk. It was really wonderful. I just have few things like if there's a really a poor responder, do you have patients who have little lower number of days of stimulation? Like someone who's ready on 7 days or 8 days of stimulation, then do
Yes.
you trigger?
The reason why it happens is that one is the follicles, the baseline follicle size is much bigger when they do. You'll
Yes,
see
yes.
very less theca, and you'll see small ovaries with larger follicles. They stimulate quite faster. One is because what is AMH? AMH is a resistance marker. So its role of AMH is to hold follicles back. And that is what AMH does. So when you have a very low AMH, they escape the controls of AMH quite fast. So they recruit quite fast. So you'll see that in women, and by day 7, day 8, the evidence is that with a shorter follicular phase, egg quality is also poorer. Also, what you always have to find out is what is a woman's natural follicular phase. Now, if a woman has a 28-day cycle and ovulates on day 12 or day 13, but in IVF she ovulates on day 7, day 8, your FSH stimulation has caused that. And in those cases, you often see a poorer conversion to blastocysts even when you get mature oocytes.
So I just was going back to embryology now when we talk about nuclear maturation and cytoplasmic maturation. So do you think that we should probably wait, because we did hear Dr. Manisha talking about triggering at smaller follicle sizes. So this is that concept of HIER, higher concept, where you do a highly individualized egg retrieval. So there is something like cytoplasmic maturity is equally important for our blastocyst conversion. That is the reason we tell at least 8 days of stimulation is important. So your take on that, yeah.
I see. I think so. I equally there's some from the IVM perspective. Dr. Manisha is probably right. Because if you see in IVM, you do get good blastocysts at the end. So, I think mitochondrial function and cytoplasmic maturity is so much gray area that we really don't know how much of it that's important. Uh, uh, when you look at the time lapse images of many follicles that have poor cytoplasmic maturity, you see a lot of granular formation on the time lapse machine, and that what I think is if there are women who produce good blastocysts with a lower follicle size, that's good. But if they don't, then there's something wrong with the cytoplasmic maturity.
So the number of follicles and the size of the follicle, is there any change depend on the day of trigger? Like when you want to trigger day, if the age is advancing, do you want to trigger a little early?
I don't. I generally wait till the follicle size is at least 16. At least and once you have 13, 14 millimeter follicle, I take a step back and I then contemplate whether a dual stimulation is worthwhile. See, for example, you've got a 12 to 13 millimeter follicle. Are you going to risk collecting it, or are you going to give an analog trigger and say, see, you've got 5 follicles which are 12 millimeter? I think we can try and stimulate this in the luteal phase. Why? Because these are in the second cohort. When did they recruit? They started recruiting by day 10, day 12, or day 9, day 10. So they were not meant for a day 14. So I would rather move this into a dual stimulation and say, you've got 5 follicles,
Okay.
let's try and stimulating it again.
Yeah, yeah. Right, that makes sense if there are more.
Dr. Seema, you're there.
Yeah. Yes, I am here.
Anything
I'm just
from your side?
Yes, this is something I just wanted to understand this. And no comment, yeah. I'm just
So,
learning.
any role of growth hormone, your experience on growth hormone?
No, I tell patients we'll try and make you a bit taller. But I'm not very
What about
convinced.
ovarian
My
Sorry?
question, I know the
Sir,
same
ovarian
question.
PRP, sir, are you doing? Is it helpful?
No, but I don't know. In the UK, it's not allowed to be done. So, but in India, it's done. It is done in the Middle East, and it's done in Greece, and so a lot of patients go there. Now, the reason why I think we may get an answer in a few years is that IVI has started running a project called ovarian rejuvenation. The reason I would trust IVI is that traditionally IVI as an IVF service is based worldwide, and they are huge across the world, and that they have started using PRP will give us in 5 years or so an idea whether it is worthwhile. So if you look at science, I've forgotten what it's called in science, that when a new technology comes, it seems to be a saver. Over the period of time, 99% of new technologies have proven to be useless. And that is how science has gone. You look at every evidence. I have a feeling that PRP may go the same way, but I'm more than happy to be proven wrong. But I'll wait for what IVI comes up with, because elsewhere I'm not willing to accept anybody else's data, because they'll come up and say, I do PRP, it works brilliant. It's your data. What have you pitched it against? You pitched it against no external review. You pitched it against you looking at your own data, coming up with a result. I won't believe it. till you come up with a standardized process that can show to the world that it's working. IVI might do it, and if IVI does it, I think it will open up new doors.
Can
Any
I
role of
ask a
steroids? Yeah.
question, Anuradha? Can I ask a question?
Yes, ma'am. Well, the
Yeah.
forum is open. Yeah.
Okay, just to learn more from Dr. Anil, you talked about the mitochondrial dysfunction or the role of function. Mitochondrial is very gray area. Can you enlighten us something that how these people, the research people, are going to measure this mitochondrial function or study this, and in which cells, which are these cells which will be important, because these are cell organelles.
Yeah, about 5-7 years ago, we used to start doing. We were doing mitochondrial DNA. We used to try and quantify it, but we
Okay.
don't. We really have not really become any wiser. We
Okay.
stopped doing that about 5 years ago.
Okay.
The
But you had taken the mitochondrial from where? Is that from the patient thing or in the IVF stage at any
in the IVF
embryo time?
stage, so there's to
Yeah.
collect the cell structure, and then run a mitochondrial assessment. But I think it was completely
Okay.
useless. Now,
Okay.
for example, see, there's an American clinic called OVA something, and what they did is they did a 3 IVF person. At present, mitochondrial transplant is done for mitochondrial deficiency, and you must have read the news that 8 babies have been born in the UK. So what they do is they take a donor egg, they remove the nucleus from the donor egg and replace it with the mother's nucleus. So you're literally renting the cell structure of the donor. Now, what this American clinic has done is they've said the problem with women who have a poor reserve is that there's something wrong with their nucleus because there's aneuploidy. So what they've done is they've tried to give a new nucleus of a donor nucleus to a woman with a low AMH. Results have still been bad, which means that as you age, not only do you create more aneuploidies, your batteries also get weaker. And can you improve the batteries? Do I want to be 25-year-old? I really do want to be 25-year-old. Can I? The answer is no.
Yeah. Yes. And those mitochondria, I think you talked about also the mitochondrial disorder. For that, they are using that approach.
That's correct.
Wherever there is a maternal, disorder, mitochondrial function, because they are from mother. So that they are trying. From that point of view, I was asking. Thank you so much. Excellent talk.
Thank you. The
Mr.
only
Gudi,
thing
a question, if I may.
Anil Usha is a
from a mythological point of view, if you've
is in
read
Bombay.
if you have read Garud Puran, and Garud Puran
Yes,
says
and it is
that.
us and a very good friend. And thank you, sir, for being here.
No, I'll tell you a story before I go. I said from the Garud Puran, it is said that the energy comes from the mother. The Garud talks about life and death. And many of us did not, we thought it was a joke. But when you look at embryology, almost every energy cell a human being has comes from the egg, not from the sperm.
Yes. Thank you.
Okay.
One
Bye-bye.
question
Thank you very
before
much.
you leave, sir, if I may.
There is
one question. There is one question in the
if I can
box.
ask.
Can we finish
Hi,
that
Pratik, go ahead.
question?
Yeah, I wanted to ask, in your experience in the UK, how accepting are couples for this concept of egg pooling and embryo pooling?
Quite open to the concept is.
And since it's funded by the NHS.
No, not at all. Only, in fact, NHS funding has gone down because the government doesn't have money. So NHS funding has gone down. Much of it is private. I see the quest of everywhere around the world, the quest of wanting a baby. People will sell houses, will take loans, will do everything possible. And it happens in India. It happens everywhere. It's the same. There is. I've seen people take tons of loans. I've had somebody who has spent £150,000 when she came to me, which is how much? 1.5 crore rupees.
So in my experience, it's hardly 10 to 15% of couples who accept embryo pooling as an alternative. But these are the couples who strongly are motivated by having their own eggs. They don't want donor eggs at any cost, either for religious reasons or for family reasons, whatever.
See, generally, what tends to happen is in India, donor eggs are accepted better. From a culturally and religious point of view, it is donor eggs are not viewed as anti-religion to a large person but equally, I think often to keep the costs down and to keep a relationship going on. Often who sacrifices the most? It's almost always the woman who sacrifices the most. So women opt for donor eggs because they say, at the end, I want to have a child. I want to get this going. And I think that's the reason why donor eggs are better. In the UK, people will try and push for using their own eggs.
Thank you. Thank you, Dr. Budi. Apologies for keeping you.
No, thanks a lot, Pratik. And Seema and Dr. Khal, thank you very much. And it was a pleasure as always.
Thank you, Dr. Anil. Thank you
Thank
so
you,
much.
sir. Thank you. Thank you.
So we'll move on to the last.
Thank you.
Thank you. We move on to the session 3. Is there a role of ovarian rejuvenation in poor ovarian reserve by Dr. Lavanya Kiran? So, Dr. Lavanya? Yes. Where's her CV? Please display the CV. Dr. Lavanya is based in Bangalore and she's with Kaveri Hospital. She's an IVF specialist and a robotic surgeon. And there's a lot of, awards and accolades. And she's a good friend.
I think we're all needs will carry on.
Yes, I think we are running short. So you start your presentation. Please share it.
Yeah. So actually, I would at the offset thank Dr. Seema and Anu for giving me this controversial topic. I was thinking, should I log off when sir was talking about, how the AMH, when it is low, nothing is going to respond. Seriously, I was like in the flight mode of switching off and saying, okay, I'm not going to do this talk. But I think I agree with Dr. Pratik was also saying that how patients are willing for these egg pooling, embryo pooling. And, I wouldn't agree with Dr. Goody saying that a lot of people in India are completely okay with going ahead with oocyte donors. I don't think quite a few of us agree here, because even here in Indian population, I think they still try and make sure they at least try going through one stimulation cycle to make sure they have their own progeny. And I'm sure that clan is increasing quite a lot. And we do understand that AMH is low or we have a poor ovarian responders, but we all do get these kind of patients who really still want to go ahead with stimulation protocols. And we're all trying our best to make sure what do we do. Like sir said, of course, we don't have these strict protocols or how do we do it. There are no standardized procedures here because everybody is coming up with their own procedural techniques. And I think it's something that time has to tell us, is this good or not? So such treatment protocol is regenerative medicine, where I say it is an emerging field which is gaining a lot of attention among the gynecologists, the fertility specialists, because it is something where it works on improving the functionality, and then it is a very potential kind of therapy where you can use embryonic cells, adult cells, pluripotent stem cells. We all know this regenerative medicine is something where it regenerates the tissues and it also tries to restore the normal functioning of a cell. That's mainly because of the growth factors. And these growth factors, I think we all agree that the platelet-derived growth factor, the fibroblast growth factor, the epidermal growth factor, the transforming growth factor, vascular endothelial growth factor, all works towards repairing the cell, regenerating the cell, and also regenerating newer forms of cells. And it also helps in wound healing, increased vascularity. And these are the same things which is used to make sure that it works well. And we get these stem cells through either the it's been used in several patients in the past, like diabetes, spinal cord injuries, Hodgkin's disease, stroke patients, and we are not anymore behind. So the gynecologists and infertility specialists are also using here. So these stem cells are basically undifferentiated cells where they have a capacity to differentiate into 200 different kind of cells when they are put into the right condition, when they have an appropriate condition where they self-replicate, self-renovate, and form an undifferentiated cell where they can produce a specific cells. So we can get these cells from the umbilical cord, bone marrow, peripheral blood, and adipose tissues, now dental pulp. And what is the concept of why this shouldn't be working? So I'm going to tell you a little bit about physiology. Dr. Sachin sir spoke so well about it. See what happens in POI patients. The ovarian follicle numbers and the primordial follicle pools are getting exhausted. Because of this, what is happening? The FSH is becoming high. The AMH is coming down. The E2 is also coming down. So in turn, what happens? There's an increased oxidative stress, reduce antioxidative agents, mitochondrial dysfunctions there, pro-inflammatory cytokines are increasing. We have the inflammation network increasing, the acceleration of the follicles, which is going into dysregulation, apogenesis is all increasing, and also ovarian fibrosis is all getting disrupted. Now, when we use the stem cell, like I said, the right environment and in the cells divide in its capable forms. Assuming that you put it into the right patients where it can still trigger. So what does this do? It reduces the atretic follicles. It increases the primary and the secondary follicle. It also brings in follicular neogenesis, where an optimal environment is very, very important. This is why it needs to be very stringently used in patients where the FSH is not very high. We, of course, see the FSH come down, AMH to an extent go high, and E2 also becoming a little better because the ROS reduces, the antioxidants increases, and the mitochondrial transplantation also increases. It reduces the pro-inflammatory cytokine starts coming down, anti-apoptic factors increases, and autoregulation starts happening, and also increases the angiogenetic microenvironment axis starts becoming better, and new angiogenesis starts happening. With this, we understand that, we have a lot of women with decreased ovarian response is different. Premature ovarian insufficiency is different. And this is why I said we have to use it in a very, right patient and subset of patients has to be much important here, because the option of oocyte donation is always there. But then the couple have to accept, and they always want to try and have their own genetic child. And that is how we also started thinking, how do we use regenerative medicine into helping our POI patients, and how do we help them? So we decided to do a study of 85 patients over 3 years, 2.5 years precisely. And we tried to see if there was any ovarian function improvement. Did the AMH get altered, antral follicle count, and did the FSH happen, and what was the success rate? So AMH was measured, AFC was measured, FSH was measured at the starting, again 1 month later and 3 months later. So while we wanted to see the response, we took patients not FSH more than 15, because we all know FSH very high, AMH very low, we are not going to have a response. So AMH less than 1, antral follicle count less than 5, the age is in the combination of above. And of course, Bologna criteria was all used to see how they progressed. And the exclusion criteria, if they had very low ovarian reserve or very high FSH, they were not included. So the number of oocytes were seen, the embryo form, the clinical pregnancy rates, the ovarian markers like AMH, AFC, and FSH was checked. So here we saw that, it was a 95% confidentiality, and the forest plot was all done here. And where we saw that, yes, stem cell was definitely a game changer is what we thought initially. And we saw how do we scale up these things and how do we implement it. I hope my videos work. So initially you have to, I prefer getting my orthopedician or my hematologist. Luckily, I'm in a multi-specialty hospital where they're all just a call away for me. So better to use a Jamshedi needle, iliac crest, either the anterior or the posterior can be used. And you have to draw nearly 20 to 30 ml. And this is drawn in a syringe which is heparinized so that it doesn't get clotted. Please remember, every 10 ml of bone marrow blood that you draw, you're going to get only around, after processing, only around 1 ml. So you need to have anything around 20 to 30 ml, because to inject it into each ovary, you'll need anywhere around 1 to 1.5. So once the blood is drawn, which is heparinized, and the processing has to be started, where preferably try and use a cold centrifuge, and you can use a GCSF the previous 24 hours prior. So you have better growth factors in your blood. So you use it at a spin of 1800 RPM for 12 minutes. Try and take out the buffy coat and try to do the second spin. So this is the buffy coat here. So when we are aspirating, we have to start with the buffy coat first, and then you also take the plasma. You can use falcon tubes, and the second falcon tube does not have to have an apparent. So you do another spin with 3200 RPM, and you do it only for 6 minutes, and then take the buffy coat. So this is the first one, and you'll have to start using it for patients where, so sorry, let me, yeah. So you can start using it for injecting to the patients. So we've had patients where we have used it for patients who've had very poor quality of oocytes, or we've had patients, had very less M2. And these are the patients we had recruited for the patients. And these are all patients in the past, my patients, and again, they had come for the second cycle. So we were wondering, how do we get them to, have a better number of oocytes? So that is where the patient's data come from. So it is not a comparison between two different doctors. Of course, they're all not randomized studies. And you can do these installation even through the ultrasound, where, you'll have, since all the fertility doctors keep doing their own scans, you definitely know, is this something that you can do it by transvaginal ultrasound installation or laparoscopy? Because if the ovary size is decent, I think you can do it vaginally. And if the streak ovaries, it becomes very difficult to do it vaginally, because it starts slipping. You're not going to enter the cortex. Sometimes it is so difficult even to do it through laparoscopy, because holding and going under the cortex is also difficult. So if the ovary size is decent, then you can do a transvaginal. If it is too small, then laparoscopic is a better choice to do. And imagine something like this. If you have an ovary and these are streak ovaries, to inject, because you're going to only puncture. So you're not even going to go there, because the cortex, the ovarian volume, everything is so low, you are not even able to going to be finishing the procedure. Imagine you're doing this kind of a streak ovary in transvaginal. I think it's very difficult. So looking into the results, we saw that AMH had increased in 17% of the patients to 0.8, 50% from 0.5 to 0.8, and 28% there was no response seen. And in 5% of the patients, absolutely the AMH reduced. So its consent is something very, very important for these patients. And I think we have to tell, when we are waiting, we know everybody knows with the increase of age, AMH definitely reduces. So the AMH can fall as well. So talking to them and telling them that this is not a sure shot treatment, this is just a prophylactic treatment. I think consent and not over promising your patient is something very, very important. And we had seen that, significant improvement in antral follicle count were seen. FSH values had reduced for quite a few patients. FSH had dropped down. We had a patient whose FSH was 90 and it dropped down to 30. 2 patients of that kind. And a lot of patients didn't have menstruation at all. 3 of the patients started having, natural cycles, and that itself made them happy. Of course, they have not yet conceived, but that is a joy for them, that they don't have to keep taking a pill henceforth. Our successful pregnancy rates were around 13%. I know 13% doesn't sound so great, but these are the patients who would have been a candidate for oocyte donors. So at least I'm happy that 13% of the people didn't have to go to the oocyte donor. We can see that, in the pre-treatment, we had 5 oocytes, but post-treatment, we saw there were 10 oocytes. M3 had increased from 3 to 8. It's the same patient data, where we had 3 fertilized embryos, and post-treatment, we had 8. Another patient where pre-treatment, we had got 5 oocytes and later 7 oocytes. M2 had increased from 3 to 6, and fertilized embryos from 1 to 5. And similar data where the AMH had got better, FSH had fallen down quite well. And like I said, yes, pregnancy, 13%, I would say is definitely good value, where the embryo formation was much better. And the number of oocytes, what we retrieved was also much better for our patients. Antral follicle count were also all good. AMH though didn't have much of it, but changes, but at least the p-value did show a difference for us. FSH also had fallen down. But I always say that the limitation is there because no standardization of the preparation method or the dose of stem cell injected, or there is no consensus basically. And I think, like Dr. Goody said, this is something time will tell us. And high time that we make consensus. Randomized studies are something very important, and larger studies are definitely required to see if it is going to work well. But totally, I think over the years of understanding the physiology, listening to stalwarts, changing your protocol, I think the number of stem cell procedures that I would do comparatively to before has come down drastically. Only last week, I had 2 patients with 0.6 and 0.4, didn't do any stem cell. They were for all egg freezing, and we got 5 oocytes from the lady who had 0.6 and 4 oocytes from the lady who had 0.4. And I think that is something good. So I think improving and working more on the protocol based, being frank to the patients, telling them what works, what doesn't work, and consent is something very, very important. But I would definitely say intraovarian stem cell injection in POI will improve the antral follicle count, number of oocytes, embryos will improve. But the larger multicentric randomized control studies are required where stem cell preparation can be concerning, and the amount of stem cell injected, the frequency of how routinely do you do this is something we have to wait and watch, and for now could be used other than altering your protocols. And once you have lot of patients, I think we start different techniques, and we tried using the spinal needle because we wanted to reduce the number of incisions, because sometimes patients would have gone through so many procedures, and we wanted to try to reduce the number of ports. So we used a spinal needle, held the ovary, brought it up till the abdomen, and then used a spinal needle to inject our preparation. And this patient did have better number of oocytes, and we also reduced, and the patient was also happy to get a better results. It serves as a game changer, and definitely scoring for patients much better for oocyte quality improvement, and works very well with thin endometrium patients. Pregnancies have been much better. Since the scope of today was only ovarian regeneration and poor responders, I stuck to this thing. Thin endometrium stem cell definitely works quite well. And I do understand this is something relatively new, and as of now shows a favorable results. And of course, it is safe for patients because it is autologous, and we don't have to be worried about any any other thing. But of course, there's a lot of controversy on all the legal litigation and the licenses that you would need. But you should remember, if you're using it in the same sitting and you're not trying to separate out cells, then you don't need a licensing, because it is at the same time you're processing and injecting and not reserving and using it as a different setting. So of course, if you can have a stem cell study where you're looking into the kind of CD4 counts, everything, if you're going to do, and I think that would be a better thing to do. We always have to remember that it's a process where science becomes medicine, and we should minimize harm and maximize the effectiveness. And I think that is what is more important for all of us as doctors. Thank you so much for this wonderful opportunity.
Thank you so much, Dr. Lavanya. One last point, we are running late, but what is your take on PRP? That was the question, Dr. Anil, we discussed.
Yes.
Bone marrow is a different entity. I think a lot of people might not be able to do it, and but PRP is an easier procedure to do. Just draw blood and separate the platelets. So the platelet-rich plasma. So can you please tell any thing about that? I mean, your experience about
Definitely.
PRP injecting into ovaries.
I started this journey with PRP, but over some time, I think I realized that the stem cell effectiveness on these ovaries are going to stay for a longer duration compared to a PRP. So the efficacy of a PRP would stay for not more than a month or 2. But when you do a stem cell, I have patients who are coming back even like a year and a half, and still their AMH seems to be sustaining. So I've had 2 patients who come back for the second pregnancy after the first stimulation, and the AMH, I'm glad, is still maintaining somewhere around 0.8 to 0.1. And I think this is the only difference between PRP and stem cell, where you have the results is going to stay for a longer duration. But compared to the ease, yes, definitely, when you have no access to stem cell, PRP should be better approach compared to a stem cell. But the only small trick I would say is like you can use a GCSF injection, so our results are much better or as equivalent to a bone marrow aspirate is something that we can think of.
Dr. Seema?
Yeah, Lavanya, it was an excellent presentation, and you don't need to worry. Every new thing is condemned and criticized first. So it's us only who make these evidences and we break it. Till we are going in right direction, doing all the things as ethical as we can. If it works, we will continue doing it. If it doesn't, we'll say it is not working. So that's the way medicine as well. Then I just wanted to give a pointer, a word of caution in patients who are having subclinical infection, chronic infection, just like tuberculosis or something. All those things should be ruled out before we are going to drill the bone marrow. And that is a very important lesson I learned through one of my patients who had undergone this stem cell PRP in endometrium, and later on she landed up with acute tubercular abscess in this anterior iliac spine. So please be very careful about all the infections. Do it properly, and until unless you are culturing it, as Dr. Lavanya said, require a license to practice it. But be really vigilant about the candidates you are choosing. In certain patients, especially where AFC is already 5-6, there if it is not improving the number, maybe those growth factors are improving the quality of those oocytes. Maybe some kind of influence. We talk about endocrinological paracrina, index, crosstalk, whatever it is doing, but something is being done and it's really, really working well for those where it is. But we really need a bigger trial and we should come together to do it. And I have heard about your 3 natural pregnancies. All these newer avenues, be it OTC or this regenerative, this stem cell PRP, injecting in the ovaries, the chances of natural conception always become more, because for IVF we need number of sites to create that particular blastocyst. Thank you, dear. Thank you so much.
Thank you so much. Thank you for this wonderful opportunity, Dr. Anu and Dr. Seema.
So I am really elated today. I must tell everyone that what a wonderful session we had. And Dr. Seema, thank you so much for all your support and the way the things were put together. A big thank you for Corona Remedies for giving us this platform today, and they are so supportive. And a special thank you to Mr. Darshan, who has coordinated this program.
दर्शन विपिन आज आके मेरे को बोल के गया मैम आप अभी तक ओपीडी में बैठे हो 7 बजे से अपना वेबिनार चालू है and thank you. And
It's my pleasure, ma'am. It's my pleasure to hear all of you. Thank you so much.
And Darshan, really applause for you, for
we
Darshan.
keep coming up with these kind of sessions where
Thank you, Seema. Thank you, Anuradha.
Dr. Usha, thank you, and thank you, Dr. Vandana. Dr. Arshi
Thank
is
you.
there, I know, but she's not showing her face, and we can stop the recording. And a big thank you to all the audience who have logged in and who have listened to this wonderful session. And it will be available elsewhere on social media, on YouTube. So those of you who have missed, you can log into the YouTube of Cor-Connect and you can listen to these wonderful lectures.
Thank you. Thank you, Dr. Seema, Dr. Anu, for having me here.
Thank you.
Thank you so much. It was very engaging.
It was, and let's keep interacting and doing things and learning from each other. And any topic you guys are interested in, let's decide and we'll go ahead with that. Thank you, viewers. Without you, we are nothing. So saying goodbye for now. Take
Goodbye.
Thank
care.
you.
Good night.
Goodbye.
Good night.
Bye.
And
Bye.
have
See you,
a great
Lavanya. Thank you so
Friday,
much.
Saturday, and Sunday. Bye.
Yeah. Bye.
We'll
Bye.
meet
See you.
again next month. Thank you.
See you. Bye. Bye. Bye.